for a test. 1 minute, sorry. Dr. Yasmin?
Hello. Good afternoon.
Good afternoon. Can you just share your slides so that we may confirm that your slides are, we don't have problem
Sure.
during the presentation. While I'm the course
Sure.
Dr. Yasmin.
So it shows host disabled participant screen sharing.
Just try.
So you need to allow me to share the screen.
I think you are done now. Okay, can you?
Just let me check. Yes, I can. Can you see my slides?
Yes. Can you change a few slides? Okay. That's okay. Yes, we can.
Sure. Great. Thank you.
Okay. Can you just stop the sharing? Dr. Yasmin, can you just stop the slide sharing?
Yes, I'm trying to.
Okay. एक मिनट लगेगा So, बोलना तो सुनिए थे नहीं. So we have 1 minute more left. Since we are sharing this on different social media, we just want to keep it for 1 more minute so that all the participants will get it, what actually is going on. screen share. Entry गरेकोहरूलाई एडमिट गरिदिँदै जानु. I think we'll start now. It's, am I audible? Okay. With due respect to our president, I would like to start the program. Good afternoon to all dignitaries. Respected President SAFOG, Dr. Rohana Hatatua, sir. I think we are also to General Secretary SAFOG, Dr. Yusuf Latif, sir. Respected Chairperson of Oncology Committee, Dr. Alia Begum, ma'am. I would like to thank you all for bestowing me this opportunity, for making me a part of this prestigious program organized by SAFOG Oncology Committee. I am Dr. Kirtipal Subedi, member of SAFOG Oncology Committee, and will be moderating today's program. Though we had dreamt of conducting this webinar on May 2022, but due to some various unavoidable circumstances, it couldn't be held then. And today we are here together with our renowned personalities in the field of Ghanaian oncology. Now moving to the formal program, I'd like to first play national anthem of our song, but which is on a modified version. And I think the video is more interesting on this song. So I would like to play it for a few 2 minutes. I know. Thank you, everyone. Now we'd like to meet registrar more formally. So I would like to invite our President SAFOG, Dr. Rohana. Rohana sir for the program. He is President SAFOG and Chair Committee of Menstrual Disorder FIGO. He is former Secretary General of Asia Oceania Federation of Obstetrics and Gynecology and Chair of Nine Wells Care Mother and Baby Hospital, Colombo, Sri Lanka. I request President Dr. Rohana sir for his presidential speech.
Thank you, Dr. Kirtipal, for that kind introduction and give me an opportunity to speak a few words. Good afternoon, everybody. And firstly, I am thankful to the Oncology Committee for organizing this webinar on ovarian cancer. Are we evolving? This has been organized by the SAFOG Oncology Committee in association with, I think, NESOG through Dr. Kirtipal. So I thank Dr. Alia and Bhagya Lakshmi, the chair and the co-chair of our SAFOG Oncology Committee, who have been working very hard. I mean, they are really working with so many programs in the last few months. And so this is another one of their webinars which they have organized today. So as we know, the ovarian cancer is also one of the cancers in women, which is, I mean, very complicated and very has very serious consequences. And diagnosis is late, and so the mortality and the morbidity is quite high. So this is an area which is evolving, and also we have to update our knowledge, and so that our patients benefit from it, because it is cancer which is we gynecologists don't like very much to see, because by the time you see the patient, sometimes they are in very advanced stages. So I think, so this is very timely that the Oncology Committee has chosen ovarian cancer for the discussion today. So I see that they have come up with a very nice program. Yeah, they will be discussing about screening, then the role of color Doppler, and then whether the cytology of frozen section, imprint cytology of frozen section is taken, so that there is a debate about that, and whether primary surgery or interval surgery is used in advanced cancer, and of course fertility, preserving surgery, and immunotherapy. So these are things which have evolved, and there are so many controversies, and which we maybe like to listen and discuss and learn from today's webinar. So I really congratulate the organizers for involving speakers and chairpersons from all our member countries. So Nepal, Bangladesh, and Pakistan, Sri Lanka, and all these countries I see them participating. And I am thankful to our the executive board members, Professor Rubina Sohel. I think she is a real live wire in our federation. She inspires everybody by participating in almost all the programs. Likewise, our Deputy Secretary General, Professor Varhana Devan, she is also very helpful and very supportive to me in carrying out the activities in the Secretariat. I think Professor Yusuf will join us later. And so I'm very happy, and I am very fortunate that we have very active executive board members who are contributing to all our programs. So I don't like to take any more time of yours, because there's much to listen to rather than talk. And also I see Dr. Michael from UK also participating, and thankful to him for joining us in this program. I think he had some very short notice, I suppose, but still for all, we are very happy to see. So I think we will get on with the program, and thank you very much for inviting me and giving me this opportunity to speak. Okay, over to you, back to you. Thank you.
Thank you, sir. Thank you for your wonderful words. And always, these words have been always very inspiring for us. Then I would like to invite Chairperson of SAFOG Oncology Committee, Dr. Alia Begum Aziz. She's FCPS FRCOG, Masters in Health Professional Education, and she's Chairperson of Oncology Committee. She is a associate professor and gynae oncologist with Director of the Fellowship Program of Gynae Oncology, Department of Obstetrics and Gynecology, Aga Khan University, Karachi, Pakistan. I would request Oncology Committee Chairperson SAFOG, Dr. Alia, to say a few words on aims and activities of SAFOG Oncology Committee.
Hello, can you all hear me? Hello?
Yes, ma'am, we can hear you.
Okay, sorry, I was not unmuted, so I was unable to speak. Good afternoon, Assalamu alaikum, namaste to all the participants and to all the executive committee members. And I'm thankful to Professor Ruhana for supporting us in all these oncology committee initiatives. And I must thank Professor Subedi for taking this initiative from Nepal this time, and Professor Bhagya Lakshmi for helping in all these initiatives. So SAFOG Oncology Committee, as Professor Ruhana said, under his kind guidance, is very active. And we are currently, the theme we have selected for our committee is cervical cancer elimination. And we know that cervical cancer is the 4th most common cancer in the women worldwide, and it is the leading cause of cancer death. So if you look at this, we are talking about SAFOG countries which come in South Central Asia, and cervical cancer has got an age standardized rate of quite high. It's about 15.3%, and more than 50% are dying from this disease. So if we look at the burden of cervical cancer in SAFOG countries, we have about 200,000 cases of invasive cervical cancer per year in SAFOG countries, and about half of them die from this cancer. And SAFOG believes that cervical cancer is a preventable disease with vaccination, screening, and early detection. So the first initiative which we took was quarterly webinars in order to increase awareness and increase knowledge about the SAFOG member countries, gynecologists, and PG trainees. So the first one, the first webinar which we took was on 17th November. This was to commemorate the first anniversary of WHO cervical cancer elimination launch. a year ago. And this was a very effective webinar. We had members from different countries, FIGO, WHO, CRO, who gave speeches, and we have a felicitation ceremony, and we acknowledge people who are working in this field in different SAFOG countries. So this is just a glimpse of our webinar, which was held on 17th November last year. The second one was to commemorate the World Cancer Day on 4th February, and this was done by our Bangladeshi colleagues. They took the lead in it, and of course, all the SAFOG countries participated. Again, the theme was elimination of cervical cancer by 2030, not beyond us. And you can see that participation of all the countries, and it was also very well attended and very well acknowledged. The third one is what we are having today, and now we are talking about ovarian cancer, and we have a rich program today as well. There are a few other initiatives. Of course, we recently got a grant approved by CRO for a research project, which is a training project of FOXI members in Mizoram, India, to do augmented VIA, thermal ablation, and LEAP. The aim was to enhance skills of gynecologists in this region to eliminate cervical cancer. This is a $30,000 grant, and Bhagya Lakshmi, myself, Dr. Nirja Bhatla, and some other gynecologists from India are participating in it, and we are going to start shortly working on this project. We are also developing a theoretical gynecologic oncology course for the gynecologist of the SAFOG countries. We are going to get it approved by the executive board shortly, and hopefully this year we are going to launch this online course, which will benefit many others. So in summary, the South Central Asia of SAFOG countries, it accounts about 60% of the world population and half the global burden of cancer. And the incidence of cancer is estimated to increase from 6.1 million to 10.6 million in 2030 due to aging and growing population, lifestyle, and socioeconomic changes. SAFOG Oncology Committee will continue its efforts towards prevention, early detection, and treatment strategies to reduce the burden of gynecological cancer. So today's webinar is one step forward for this effort. I would like to thank Professor Subedi for giving me a few minutes to share what we are doing and what we plan to do. And over to you, Dr. Subedi.
Thank you so much, ma'am. Thank you, Dr. Alia, for enlightening with us the SAFOG Oncology Committee activities for all of us. And SAFOG is providing wonderful platform to all gynecologists and gynecologists of this region. Thank you so much, ma'am. Now, with due respect and permission of the officials, we would like to begin the scientific session. The first presentation will be from Dr. Michael Sedris with this topic, screening for ovarian cancer, where we are. To chair this session, I would like to request Dr. Niranjan Chavan and Professor Dr. Sahana Parveen. Dr. Niranjan is Professor and Unit Chief and Joint Treasurer of FOXI with Vice President of Homologous. He is Member Oncology Committee SAFOG, Dean of AGOG, and Chief Content Director of IGRAD and Ethmois Guidelines, Editor-in-Chief of different journals. He has more than 50 publications in international and national journals. And he is National Coordinator of FOXI Medical Disorders and Pregnancy Committee, Chair and Convener of FOXI Cell Violence Against Doctors, and Coordinator of 11 batches of MUH Recognized Certificate course, and is Member Managing Committee of IAAG, Editorial Board of European Journal of Gynec Oncology, Course Coordinator of 3 batches of Advanced Minimal Access Gynae Surgery, and still more, he has lots of recognition. So with this, I would like to introduce Dr. Niranjan, and I would like to request Dr. Niranjan to introduce our speaker, Dr. Michael. And we do have Dr. Sahana Parveen ma'am also, and she is a professor of gynecological oncology at National Institute of Cancer Research and Hospital, Dhaka, Bangladesh. I would like to request Dr. Niranjan to introduce our next speaker, Dr. Michael. Niranjan sir. Niranjan sir.
Muted. He's muted.
Thank you so much, Dr. Kirti. It's an honor and privilege to be here as a chair of the first session on ovarian cancer, which has been organized by the SAFOG Oncology Committee under the leadership of Dr. Rohana and Dr. Yusuf. Nice to see you, Rohana sir. After a long time, we are meeting again after April when I got installed as a chair and the president of MOGS. Thank you, Dr. Alia, to invite me today, and Dr. Bhagya Lakshmi. It's also nice to see all of the colleagues from Nepal and our South Asian countries which are a part of the SAFOG. So I get the honor and privilege to introduce the first speaker. It's none other than Dr. Michael Sedris. He is a graduate from the Medical School of Athens since 2011, and then he moved to UK to pursue his PhD and MRCOG. He has done a doctoral thesis in the molecular biomarkers of early rectal cancer at the King's College, London. He has a lot of papers to his credit, and currently he is working on Gynecology oncology as a subspecialty of the Royal London Hospital. He is also the academic clinical lecturer in Gynecology oncology at the Wolfson Institute of Preventive Medicine. And this has been under the supervision of Professor Ranjit Manchanda. So I welcome Dr. Michael Sedris to talk upon the screening of ovarian cancer. Thank you so much for coming. I hand over the mic.
Thanks so much for the kind invitation. Can you see my screen?
Yes, we can
Okay,
see.
thank you so much. Thanks also to Subedi, and thank you to SAFOG committee for inviting us to be part of this amazing webinar. I'm going to deliver this lecture on ovarian cancer screening on behalf of my supervisor, Professor Ranjit Manchanda, who is sending his greetings to all of you and his gratitude for inviting us to give this lecture. No time is precious, so I'm just going to carry on. So what I'm going to cover is I'm going to give a few minutes on the background of ovarian cancer screening, where we are now, and then explain the evidence behind this. So generally, ovarian cancer screening is split between low-risk individuals and high-risk individuals. So this presentation is kind of like split between the trials that support the evidence for low risk and the trials that support the evidence of high-risk individuals. And then we're going to talk through probably the future of screening. Some background terminology. So when we say screening, we mean the active search of a disease amongst healthy individuals, among somebody who has no extra risk factor for ovarian cancer. We call it surveillance when we are looking actively for a disease amongst high-risk individuals. Call me BRCA carriers, for instance. A prevalent screen is the first screen. So the screen that we do, if we screen somebody first time and we find ovarian cancer, that's a prevalent screen. If we screen somebody regular and we find cancer on the second or third screen, this is called incident screens. Ovarian cancer, as most of the keynote speakers will emphasize, is a very aggressive cancer. 7 out of 10 women will die eventually from this disease, unfortunately. and the 5-year survival is only 46%. The ones who survive around 10 years are less than 35%, and that's based on our stats from Cancer Research UK between 2010 and 2011. If you see the graph on the right side, you can see that ovarian cancer has one of the poorest 5-year survival compared to any other cancer. These are American data on the left-hand side. Similar, 49.7% survived for around 5 years. And the paper on the right-hand side emphasizes that we haven't done much progress to improve that. And unfortunately, we're still looking for effective treatments, and we're looking for effective screening strategies to eliminate this burden. So as I said in the beginning, so screening is split between low-risk individuals and between high-risk individuals. The screening for low-risk individuals, the average population, has a very big trial which was recently completed and published its data at the Lancet, which is actually a massive lesson and a massive experience and for all of us to take things forward. The screening of high-risk individuals has also strong evidence and has also very important lessons to give for the future. So where we are now, for average risk people, we don't recommend screening. There's no country globally that would recommend screening for ovarian cancer for somebody who is on the average risk. For people who are high risk, there is some kind of conflicting evidence, but not robust enough to draw solid conclusions. In the UK, there is a current ongoing review by the NICE committee, which Professor Matsamda is part of it. And we are hoping that within the next couple of years, there will be a conclusion about the recommendation. But there is no, up to today, there is no screening advice as an alternative to any risk-reducing surgery. In the States, there are some recommendations from the RSNA that transvaginal scan and CA125 may be started at the age of 30 to 35 in high-risk individuals, but there is no solid evidence. With regards to the European guidelines, the ESMO advises that you may offer screening from the age of 30 onwards on a 6-monthly basis. As I said, RCOG and BGCS, the two bodies that are the official bodies of gynecology and gynecology in the UK, do not recommend screening for high-risk individuals at this stage. But there will be an update in a couple of years' time from NICE committee. Potential harms, just to close the loop of the background. If you screen for a disease or if you do active surveillance for a disease in high-risk individuals, you may find false positive screens. And these false positive may undergo surgery, which has obviously physical morbidity. It's big operations that can result in adverse events, and we all have extended experience of how this can happen. Sometimes we have false reassurance because you may have not detected disease. And like, imagine the women, the stress that they undergo every time they come and visit the doctor, and they go through the same process again and again. Right, so before we start talking about low-risk individuals, I'm going to comment on the ROCA, which is an algorithm that most of the trials have based on the results. So the ROCA is an algorithm that kind of like interprets the CA125 velocity. And this graph, what it's trying to show is that using the ROCA algorithm, you have higher specificity of the interpretation of CA125. And if you see on the top hand, if you have somebody with CA125 of 100, that doesn't indicate necessarily cancer, but the trajectory of this value is the one that you should interpret. So if it's a stable trajectory, then that means that the individual doesn't have cancer. And similarly, somebody who has CA125 of 10, that can have the same interpretation. But if you see the next slide, what this is trying to show is that rising CA125 levels, even less than 35, which is a normal, can be suggestive of cancer. 70 out of 133 screen-detected cancers has CA125 less than 35. So more than half of the cancers detected from the screening have the CA125 less than 35. But again, what it counts more is the trajectory, how the CA125 increases over the time. And on top of that, 41%, a little bit less than the initial proportion, had a normal ultrasound scan, which is something I'm going to comment later on. This slide shows that ROCA is not the only algorithm. There are other longitudinal CA125 algorithms that can have similar sensitivity and specificity. And on the right-hand side, we've also tried multi-marker longitudinal algorithms for the similar purpose, which also perform quite well. Right, let's start now to talk about the low-risk individuals. I'm sure you all heard about the UK CTOX trial, a massive trial that gave us most of the knowledge that we have about the average risk population. So this trial, what the population was women are between 50 and 74, who were postmenopausal, had at least one or both ovaries, and did not have any high risk of family history. They recruited 202,000 women, and they randomized them in 3 arms. One arm was the multimodal group, 50,000 women. The other arm was the ultrasound group, and the other arm was the non-screening group, which they did nothing. So that was 1 by 1 by 2. The outcome of this trial was cancer-related deaths, and they followed up for over 9.5 years after the end of the screening. In the multimodal group, what they've done is they used the ROCA algorithm, and this precipitated ultrasound scan in high-risk individuals. So on average, we had 345,000 screens with an overall compliance of 81, and the median screens per woman were like 8. The complications reported were only 0.9 per 10,000. Similarly, for the ultrasound group, there were 327,000 annual screens with an overall compliance of 78%, and the median screens were 8 with 1.9 complication rate per 10,000. This is the first lesson from the trial. There is no difference in deaths between the multimodal screen, the ultrasound group, or the non-screening group, and that's in a nutshell what the trial concluded. In every group, the rate of cancer diagnosis was 1 in 100 roughly, as you can see on the left-hand side. And what is very interesting about the latest Lancet paper, which was published by Professor Usha Menon in 2021, is that the multimodal group on the trial had a stage shift, which means that they identified at the stage 1 47.2% more cancers compared to the ultrasound group, and less than 24.5 stage 4. So you have an earlier diagnosis of ovarian cancer, but that unfortunately did not translate to a survival benefit. So in a nutshell, what this trial showed, it was the largest RCT of its nature to date, and that can be a guide for future implementation trials, because it's very important to run a trial in a gold standard way that you get the answer you're looking for. The importance of having ovarian and tubal cancer mortality as a primary outcome, it was one of the things that was highlighted in the conclusions. And despite a 47.2 increase in the incidence of women who had ovarian and tubal cancer diagnosed stage 1, and 24.5% decrease in those who were diagnosed with stage 4, there was no survival benefit, which was the conclusion. Now let's move on to the screening of the high-risk individuals. And one of the most influential trials in this on that occasion was the UK FOX. And the ALTO project is a continuation, which is hopefully going to be published within the next year. So when we say high-risk individual surveillance, we're talking about people who are diagnosed with BRCA1 and 2. And just to remind ourselves, BRCA1 has a 44 lifetime risk of ovarian cancer. BRCA2 has a 17% lifetime risk of ovarian cancer. And the way that it works, it's in theory to get tested for BRCA, you have to have on average a 10% estimated risk according to your family history, and then you are offered germline testing. So UK FOX is a trial that, again, Professor Matsana was involved on that. And what they've done in this effort is they've screened 4,348 women with ROCA multimodal and annual scan on a 4-monthly basis for 3 years, and they follow them up after for an additional 4 years. They found 19 cancers during active surveillance and 18 cancers during the follow-up. So 19 cancers during the 3-year period and 18 during the 4-year period. 84% of them were BRCA carriers, and 92 were high-grade serous cancers. Emphasizing again on the key outcomes of this trial, what they've concluded is that if you see during surveillance, there were identified 19 cancers, 13 were during screening, and 6 of them were they were offering risk-reducing salpingo-oophorectomy. So the way they were counseling is they were encouraging risk-reducing salpingo-oophorectomy as a gold standard, but for women who were not ready to undergo this prophylactic preventive surgery, then they would do screening. So they identified 6 occult cancers during RRSO and 13 during the surveillance. And in total, 5 and 5 were stage 1 to 2. And if you see the next slide, that means that again, there's an evidence of stage C, which means you have 7 out of 19 cancers in stage 3 to 4 versus 17 out of 18 stage 3 to 4 during the follow-up period. That's a significant stage C. And that translates to perhaps more resectable disease when you operate. You achieve R0 resection in 18 of the 19 cases. You have lower use of neoadjuvant chemo, and I'm sure there's a talk in by one of the prestigious speakers later on about the IDS versus the primary debulk. So that could be, that's quite significant when you consider the outcomes. Well, also this trial concluded that there's a very high sensitivity of the screening, which is 94.7, and specificity, very acceptable positive predictive value, and also excellent negative predictive value. And for those who, just to give an overview of sensitivity and specificity, sensitivity is how well you can detect a disease in the screening, and specificity is how well you can exclude the disease. So in a nutshell, the UK FOX trial concluded that women who are not ready or willing to undergo preventive surgery, multimodal screening using ROCA every 4 months, and transvaginal scan when the ROCA indicates high risk. The ROCA, remember, is a trajectory of the CA1-5. Then the screening may be a better option than doing nothing. But when I say maybe, it means that the evidence is still not robust to recommend this as an alternative. So we say that it is not an alternative option to surgery. However, it does seem to offer a better chance of avoiding a diagnosis of advanced, incompletely resectable ovarian cancer or fallopian tube cancer in the interim. The ALTO project is a project that recently completed and hopefully will be published in the next few months' time. And the idea was to implement ROCA screening within the NHS for confirmed BRCA carriers that are not willing to undergo risk-reducing salpingo-oophorectomy. And that the rationale behind was to replicate existing clinical evidence for ROCA screening in the real-world setting in terms of high sensitivity and stage C, and to try to limit emergency first ovarian cancer presentations to the emergency departments, which is 26% for London, and also to assess the economic impact of ovarian cancer screening in BRCA carriers sufficient to allow a nice evaluation. What this project is in practical terms is 1,000 BRCA 1 and 2 carriers, more than 35% postmenopausal were also included. There were counsel about the RRSO versus that is the gold standard management, about the limitations of the screening, and the screen lasted for 1 year with 4 monthly ROCA, and the outcomes were previously described in the previous slide. So now let's move on to the future. So UK CTOX gave us big lessons and concluded that there's no survival benefit from screening. So what's next? There's the message from this slide is that the last point, that any screening program is at least 10 years away, and that's something that it does take time to create high quality evidence that can change the practice. So we need to improve the lead time. We need to improve stage shift, and perhaps we may even look for an alternative, more aggressive treatment. The way that things move forward is a more targeted approach, which I'm going to show you in one slide. some novel biomarkers that could probably identify ovarian cancer earlier than the ones we have now. There are also multi-cancer early detection trials ongoing, and I'm going to touch a little bit on a couple of big active trials that are now in the pipeline, and some algorithms to personalize risk calculation. So this is what we do with Professor Machanda. We are using a targeted approach. We are trying to stratify the population in several risks, low risk versus intermediate risk versus high risk, and counsel the women based on that about the possibility, and always having in mind that currently the risk-reducing salping oophorectomy is the gold standard to prevent ovarian cancer in a high-risk setting. The novel ovarian and tubal biomarkers, there are a lot of papers that describe circulating free tumor DNA, miRNA, and exosomes that can be very promising. And there's still very good quality evidence that is being evaluated as we speak. There are also very big multi-cancer early detection trials where ovarian cancer is part of them. And as you can see on the right-hand side, the ultimate vision is a non-invasive blood-based test that can be used to screen multiple common types of cancer in asymptomatic and healthy individuals and pick them before they are visible in the scans. And when I say visible in the scans, I mean, imagine ovarian cancer, when it's visible in the scan, it's already advanced in most of the cases. Big active trials is a DAV gene phase 3, which is what they're doing is they're using a pap smear test equivalent, which identifies pathogenic somatic mutations and uses machine learning to interpret those. It includes ovarian and endometrial cancers, and it's going to be completed in 2026, and that's from McGill University in Canada. And then the Gallery test from the NHS Gallery trial, which is an RCT across 8 alliances that will recruit 140,000 people using a blood test, and the primary outcome is the instance and stage diagnosis for several types of cancer. Then the CAN risk is also a very useful tool to calculate the potential risk and stratify the population, potential risk of ovarian cancer. And these are the disclosures. And thank you so much for giving me the opportunity to deliver this lecture.
Thank you so much. It was a wonderful lecture on ovarian cancer screening, the amount of work which has been done up till now, and so many presentations, and the papers have come out. We are still in a dilemma whether actually it is going to be very successful, because ovarian cancer, most of the time, whenever the patient comes to us in India, they are coming in the third or the fourth stage. They are very late, and that's what we have to understand, that in spite of the tumor markers which are there, or the ultrasound picture which we do, or the Doppler study which we do, we still are missing so many patients. So I think the awareness which has to be done in cervical cancer, as how we are doing for colposcopy and trying to understand, the more awareness has to be there, not only for the pap smear screening, but a need of the hour for telling our patients that if you are above 35 or 40 years of age, you need to do at least an annual ultrasound, or at least once an ultrasound in 2 to 3 years. That makes a lot of difference. But unfortunately, in spite of our best of efforts, especially in this part of the world, we still have that issues about diagnosing and preventing it to be having diagnosed early. That is a dilemma which we are still facing. I think it was great. I would request my co-chairperson to have her comments. Yes.
Yeah, thank you, sir. Thank you very much. I think you have done my jobs already. Even after that, I would like to say something, that is, even the availability of the various types of the alpha types of surgery, the various types of the chemotherapy regime, still the risk of ovarian cancer and death of ovarian cancer is increasing day by day. Even it can be, if it is diagnosed at early stage disease, that in the early stage 1, the longevity, they state that is 10-year survival is around 90%. In stage 2 disease, the 10-year survival is around 70%. But and in it is stage 3 and 4, the survivability is only the 25 to 30%. But even after that, only 25 to 30% of patients of ovarian cancer are diagnosed in the early stage. So if it is the by screening, the various types of screening, either multimodal or the single modal screening, we can diagnose the disease in early stage. But this screening is not for the population. It is only the persons who are the increase the risk, that is those patients who have the family history of the ovarian cancers or the personal history of ovarian cancer. They are the high risk developing of the ovarian cancers, and women with the inherited risk due to the genetic mutation, they have the higher risk of developing ovarian cancer. I think Dr. Michael, he has delivered all this about all the trials, who should be at the risk, who should be the screening and who should not be, and everything he concluded in his lecture. Thank you very much.
Thank you so much, Speaker Dr. Michael and our Chairperson, Dr. Nirazan and Dr. Sahana Praveen. Our next speaker is Dr. Sabira Khatun from Bangladesh with our topic, Role of Color Doppler to differentiate between malignant and benign ovarian mass. To chair this session, I would like to invite Professor Dr. Bhagyalakshmi Nayak and Dr. Neogene Somo. Governing Council member ICOG. She is Vice President of AOGI in India and Joint Secretary of AGOI. She is Assistant Editor of Indian Journal of Gynec Oncology and Peer Reviewer of Indian Journal of Surgical Oncology. And she is also Executive Member of ISDOR Executive Member of ISCCP. She has been awarded with Dr. Abha Singh Oration Raipur 2019, Dr. Shirin Mehtaji Guest Lecture Award Mumbai 2019. And our next chairperson is Dr. Neogene Somo. She is a member of Oncology Committee, SAFOG, Bhutan. She did her MBBS from Guru Nanak Dev University, Amritsar, Punjab. She is MD at Obstetrics and Gynecology in 1998 from Italy. She is instrumental in establishing National Pap smear screening program in 1999. She did her fellowship on Gynecology Oncology at Rajiviti Hospital, Bangkok. She has established population-based cancer registry system in Bhutan with as a principal investigator, and she has established a Bhutan Cancer Society that provides socio-economic and psychosocial support to cancer patients and caregivers. Now, I would like to request Dr. Bhagyalakshmi to introduce our speaker, Dr. Sabira.
Thank you so much, Dr. Kirtipal, for your kind introduction. And it's a pleasure introducing Professor Sabira Khatun, Madam. I think she's a very, very passionate worker in Ghanaian Oncology. She is the founder chairman of the Department of Ghanaian Oncology, Bangabandhu Sheikh Mujib Medical University. She has a lab at Cancer Hospital and Central Hospital at Dhaka and has a vast experience in Gynec Oncology. And her major achievements are the founder chairman of the Department of Ghanaian Oncology, was the chairman of the Bangladesh Gynec Oncological Cancer Clinical Trial Group, founder president Bangladesh Society of Cervical Cancer and Pathology, founder secretary of General Gynecological Oncology Society of Bangladesh, introduction of the postgraduate degree in Gynec Oncology in Bangladesh, and founder chairman Community Oncology Center Trust, focal point residential training on BIA and colposcopy in OGSB, and a member Oncology Committee of SAFOG. I welcome Dr. Sabira Khatun, Madam, for her a very brilliant talk which on ovarian. So I think you should take advantage of this this ultrasound. The first ultrasound I think is the best ultrasound, and take advantage of that and see what you can see from this ultrasound and how you can diagnose ovarian cancer early. Over to you, madam. Thank you so much.
Unmute. Thank you. Am I audible?
Yes, madam. Yes, madam.
Yes, ma'am.
Thank you. Thank you very much for kind introduction about me. Assalamu alaikum, Honorable President of SAFOG, Dr. Rohana Hattatua, and Chairperson of Oncology Committee, Dr. Alia Begum Aziz, and Secretary General of SAFOG, Dr. Yusuf Latif Khan, and Chairperson of this scientific session, Dr. Bhagyalakshmi and Dr. Uga Tasuni. Assalamu alaikum. My presentation, my previous slide, my previous speaker talked about the screening for cervical cancer, ovarian cancer. And from his presentation, we have come to know that there is no rule, there is no population-based organized screening program for ovarian cancer. Now, in my presentation, I will talk about the two differentiate the benign and malignancy of ovarian mass. First, in my presentation, I will discuss about the ovarian mass, ovarian cancer, why differentiation needed, and how to differentiate, and what is the role of Doppler ultrasound to differentiate in ovarian mass, and evaluation of the current practices and evidences. Now, ovary is an endocrine organ, and you see that the gynecologist, medical oncologist, endocrinologist, gynecologist, and radiologist, many subspecialists have to take care of the ovary. And we are the gynecologist, we are the gynecologist, we have to take care of the cancer of ovary. Now, our ovarian mass, about ovarian mass, and ovarian mass may be due to physiological and functional cyst of ovary. It's very common in childhood and adult women, and pathological mass of ovary. We are concerned about the pathological mass of ovary, and maybe non-neoplastic mass and neoplastic mass. Non-neoplastic mass may be chocolate cyst and ovarian abscess, and neoplastic masses may be benign tumor and malignant ovarian tumor. Malignant ovarian tumor may be found in all age group, but it is very common in the menopausal women. Now, you see that why it is necessary to differentiate between the benign and the malignant ovarian mass. You see that in a benign mass, the cells are confined in a circular space, but in a malignant ovarian tumor, the cells are exfoliated through the peritoneal cavity, and it very rapidly spread throughout the peritoneal cavity, and it becomes advanced stage. And that's why the ovarian cancer is a very lethal cancer, and the most common gynecological cancer in mortality for its mortality. What are the general rules of clinical evaluation? How we can evaluate a ovarian mass clinically? The general rules are that the pre-pubertal and postmenopausal ovarian masses more than 5 centimeters in size are usually malignant. That is, in pre-pubertal and postmenopausal ovarian masses should not be more than 5 centimeters in size. But in reproductive age, ovarian masses may be 6 to 8 centimeters in size normally, and that these are usually functional, non-endometriotic or polycystic ovary. And any hard, fixed, nodular, firm, and bilateral ovarian masses should be considered as malignant. These are the general rules for clinical evaluation of ovarian. When by clinical evaluation, we'll find a ovarian mass, that next question comes whether it is benign or malignant. Now, about ovarian cancers, few things that it is the second most gynecological malignancy in Asian countries, most lethal gynecological cancer. Only 20% are diagnosed in the early stage, that is stage 1 and 2, when 5-year survival rate is 90%. But when the tumor cancer is localized to ovary, 5-year survival is more than 90%. 80% diagnosed in the stage 3 and 4, when the 5-year survival rate is only 25 to 30%. And the lethal, it is 3 times more lethal than breast cancer. Breast cancer is the most common women cancer. But according to lethality, ovarian cancer is the most lethal. Why differentiation needed of a ovarian mass, whether it is benign or malignant? Ovarian masses are very common masses. All masses do not need treatment. Physiological and functional masses regress spontaneously. Non-neoplastic masses are treatable by medical method, that is chocolate cyst, can be treated by medical method. Benign masses need simple surgical procedure, but malignant masses need extensive surgery, including complete surgical staging. And survival rate of early stage ovarian cancer is excellent. And most important thing is that the ovarian cancer masses needs to be centralized for its better outcome. Because if ovarian cancer is treated or surgery is done by gynecological oncologist, the result is much higher than the ovarian cancer surgery done by a general gynecologist. So centralization of ovarian cancer masses needs differentiation from benign to malignant condition. How to differentiate now? Various studies and efforts have been made to differentiate, to screen the ovarian mass, to know whether it is benign or malignant. First attempts was taken as to do a yearly pelvic examination. It shows very low positive predictive value. There are 3 cohort studies. Next, the TPS was added for screening. A prospective study done on about 40,000 women. Here also positive predictive value is low. Then CA125 was added, and that also shows that the low sensitivity in early stage ovarian cancer. And by adding CA125 and transvaginal sonography, RCT was done. There was no impact was found to diagnose the malignant ovarian masses. ROCA, which has been very thoroughly discussed by my previous speaker, here also positive value is slightly increased. And RMI, addition of the menopausal status, here the positive value is more increased. And lastly, ROMA, the algorithm that also has been discussed by me, that is AC4 is added to CA125. Here the positive predictive value is much increased, but see, AC4 is not available and is very costly investigation, genetic test. Now, first, then how to differentiate the benign? The study done, the International Ovarian Tumor Assessment, that is IOTA studies, first study done in 2008, and by transvaginal sonography, addition of transvaginal sonography with color flow study. IOTA study, you can see that the 5 characteristics of a ovarian mass is studied by transvaginal grayscale sonography and by color Doppler flow sonography. You can see that the color flow Doppler sonography, addition of color flow Doppler sonography, the sensitivity of this transvaginal sonography is much increased. Transvaginal sonography, the points which are assessed for differentiation of benign from the malignant ovarian mass in international ovarian, that is IOTA, that is whether the mass is unilocular or irregular solid, whether there is a solid component less than 7 millimeter or presence of ascites in case of malignant, and the acoustic shadow or papillary structures are present or not, and whether there is a multilocular tumor and the irregular multilocular solid tumor, that is characteristics of malignant ovarian tumor. And blood flow, lastly, the color Doppler study, to see the blood flow of a mass. And the blood in a malignant ovarian tumor, the very strong blood flow. I'm coming later on how the blood flow can be seen by color Doppler. That is these are the 5 points which are studied in iota simple rules. And iota simple rules in how the masses are diagnosed as benign or malignant. And ultimately in UK, University College London Hospital, there was a meta-analysis about the iota simple rules in 2014. And they found that the sensitivity of this iota study was 93% and full specificity was 95%. And they came to the conclusion that this simple rules protocol, easy to use in routine clinical practice, and accurate test for differentiation of benign and malignant ovarian mass, and can be used in 76 to 89% of ovarian masses, and can be used by non-expert ultrasonography operator. What is Doppler ultrasound? Doppler was named after the Australian physicist Christian Doppler in 1842. And basis of use of Doppler study that the malignant cells produce angiogenetic factor, which produce neoangiogenesis of the ovarian mass, malignant ovarian mass, and there is increased blood vessel and blood flow in malignant masses. And by Doppler, we can detect this excess blood vessel and blood flow in the malignant ovarian mass. Doppler study can be done by whether that is qualitative study and quantitative study. By qualitative study, we can just assess whether there is any central blood flow in a ovarian mass. And by quantitative study, we can see the pulsatility index and resistance index. You can see some picture that in the right-hand side, increased vascularity of a solid ovarian mass. In a cystic, that is partly cystic, partly solid ovarian mass, in a solid mass, there is increased vascularity, which can be detected by color flow Doppler study. You can see multiloculated cystic mass, increased blood flow. Here you can see a solid mass where there is increased blood flow. Now, the evidences and practices about the color flow Doppler study. First evidence that is study which I found, it was done in 2003, and preoperative differential malignant from benign ovarian masses, efficacy and morphology indexing, that is plain ultrasonography and color flow Doppler, color flow sonography. This study was done in USA, and among the 442 ovarian masses in 87 to 2000. The mass was assessed by morphology index, by transfusion sonography and color flow Doppler sonography, and comparison after histopathology confirmation. They found that the morphology index is accurate, easy, less costly with minimum inter-observer variation, but addition of pulsatility index and resistance do not increase the accuracy. First study I found. And the second study in 2010, I found that they did a study in India on 100 cases between 2006 to 2007, assessed grayscale ultrasonography, color Doppler imaging, pulse Doppler spectral study, and histopathology as the gold standard. And their comparison, they did the comparison between the ultrasonography, grayscale ultrasonography, and color Doppler ultrasonography. Here you can find that the sensitivity, specificity, positive, predictive, negative, and predictive all are higher in color Doppler than the ultrasonography. And false negative and positive false positivity also low in color Doppler, and false negative also low in color Doppler. So accuracy also higher in color Doppler study. And they concluded that using both grayscale and color Doppler in differentiated benign and malignant ovarian is giving results with more accuracy, and color Doppler is better performing than transvaginal sonography scoring. Another study done in 2019, they found that this study was done in the Department of Radiology in West Bengal, India. And their study was in 2019, and they also compared the sonography and color Doppler and ultrasonography guided FNAC. And gold standard was histopathology. They also found that the benign characteristics of the by ultrasonography and transvaginal sonography and Doppler characteristics, their comparison shows that the neovascularization, central vascularity, mean systolic vacillity, and pulsatory increase all are very remarkable in case of malignant ovarian tumor than benign ovarian tumor by color Doppler study. And their comparison of the grayscale ultrasonography and color Doppler study ultrasonography, that was a very significant difference between grayscale ultrasonography and Doppler ultrasonography. Here you can see the bar graph of much higher sensitivity, specificity, positive predictive and accuracy of color Doppler than grayscale ultrasonography. Here is some picture. You can see the blood flow of a mass. And lastly, it was done in this study done in Egypt 2017-18, and case or number of cases was not so higher. And this also, there was a comparative study of grayscale sonography and Doppler, and they also seen the tumor volume, solid component, cystic component, and papillary projection wall thickness, and they compared by evaluation by color Doppler. And by color Doppler, they assessed the presence of central blood flow and peripheral blood flow. And by spectral Doppler, they show the pulsatility inlet and resistant inlet. This to see the pulsatility inlet and resistant inlet is not very difficult. It is the machine can automatically calculate this PI and RI in color flow Doppler. So this is very easy to perform. You can see some picture. You can see that is very small mass in the left side, and there is a vascularity in the right side. By color Doppler, you can identify. And septa, whether it is thick septa or thin septa, and you can see in the right side, there is in the septa there is a vascular vessel, blood flow. Now, their conclusion was that the presence of central blood flow was a significant predictor of ovarian cancer with 7.55 odds ratio. Now, lastly, I want to see a meta-analysis about the comparison of conventional and Doppler and contrast in his ultrasonography. There was a meta-analysis, and which is done in 2021. And study number was 72, and women with ovarian masses included. About 10,000 women were included, and systematically searched the PubMed, IMS, and Cochrane library until October 2021. And data was extracted was just to see the sensitivity, specificity, PLR, NLR, and the DOR, and the AUC. You can see the result of this meta-analysis, the comparison between the ultrasonography and Doppler study. You can see that the result is very similar ultrasonography and color Doppler show. All the parameters, you can see that a very similar result. And the conclusion of this meta-analysis is that the high diagnostic performance of conventional ultrasonography and Doppler ultrasonography, diagnostic performance of conventional ultrasound could be affected by the route, and the diagnostic performance of Doppler ultrasound could be affected both by route and both by country where it is done. Now, the conclusion of my presentation is that color Doppler study is a simple, easy, and less costly procedure. There is no need of separate machine. The same machine can detect assess the ovarian mass both by transvaginally and by colored study, Doppler study. Operators' performance can be gained by routine training on ultrasonography. There is no need to have a special training on ultrasonography to do color flow study of the ovarian mass to differentiate between the benign and malignant mass. And iota simple rules can be applied in almost all settings of ultrasonography. So iota, that is addition of transvaginal sonography and color flow study, can be applied in a ovarian mass. When clinically an ovarian mass is diagnosed, that according to the age of the patient, we can manage this patient ovarian mass. And ultimately, we need to differentiate a ovarian mass, whether it is benign or malignant. And the application of the iota simple rules can has a very high sensitivity and specificity to differentiate between the benign and malignant ovarian masses. Thank you very much. In conclusion, I want to say that the every of gynecology should have may have a ultrasonography machine in the practice chamber and can have a transvaginal sonography and color Doppler study of a small ovarian mass to differentiate whether it is benign or malignant. Thank you very much for your nice hearing.
Thank you so much, Sabara Madam. I think I request Dr. Ugen for her concluding remarks. So, Dr. Ugen.
Thank you, Dr. Sabera.
For all of our...
Thank you, Dr.
Yes,
Sabera,
yes.
for your nice presentation. And I agree with you about the use of ultrasound in pre-op diagnosis of ovarian cancer, because ultrasound is being cheaper. It's available everywhere compared to CT scan and MRI, and people don't need much to be trained to use ultrasound. And for ovarian cancer, because it has to be operated by a gynae onco. So pre-op diagnosis is of absolute necessity. So thank you for your presentation. Dr. Bhagia Lakshmi, if you have anything to say.
Yes, yes, Dr. Ugen, I think it's very true that in spite of going high tech, I think we should not lose touch on our ultrasound. So, and Dr. Sabera, there is some questions on the chat box. Kindly go ahead and answer them. Because of lack of time, we will not be able to take all of those questions. Please answer them on the chat box. So I think we go over to the next talk now. So in this talk, we have excellent talk by Dr. Kirtipal Subedi. And for this, I would request our chairpersons, Dr. Alia Begum and Dr. Tahira Yasmin, to chair the sessions. So I think we are already introduced to Dr. Alia. She is the chairperson of the SAFOG Oncology Committee and is associate professor at the Aga Khan University Hospital. And we have the second chairperson, Dr. Tahira Yasmin. So she is also from Pakistan, and she is a diploma, basic and immediate laparoscopy and hysteroscopy, and assistant professor and consultant in obstetrics and gynecology at the Department of Liaquat National Hospital and Medical College, Karachi, Pakistan. So I request both of you to take over the session. Request Dr. Alia to introduce Dr. Kirtipal. Though all of us now know who Kirtipal is. So over to you, Dr. Alia. Hello. I think Dr. Alia may be muted.
Yeah, ma'am. You need to unmute.
Is Dr. Alia there?
Yes, Please unmute, ma'am, Dr. Alia. I think Dr. Lakshman can.
So I think Dr. Ali is having some issues. So let me introduce Dr. Kirtipal and go ahead so we can take her expert comments at the end. Is Dr. Tahira there? Dr. Tahira? I think we saw both of them. So Dr. Ali has disconnected. Dr. Rubina has given this message. So I introduce Dr. Kirtipal.
Dr.
Kirtipal is the member of the SAFOG Oncology Committee.
Dr. Bhagyalakshmi, I am here.
Yeah, please go ahead. Please go ahead. Please
I was muted, so I'll take over.
Okay. Yes, yes, please.
Thank you very much, Dr. Bhagyalakshmi. Let me take this opportunity to introduce Dr. Kirtipal. He is MBBS, MD, Fellowship in Gynecological Oncology, Senior Consultant, Paro Parker Maternity and Women's Hospital, Assistant Professor, National Academy of Medical Sciences, Mentor of Gynecology Oncology Fellowship Program, Executive Member of Nepal Obstetrics and Gynecological Society, Executive Member of Gynecology Oncology Society of Nepal, Member Oncology Committee, SAFOG, Nepal, and we all know that today he is also hosting this session, and he is going to talk about the imprint cytology versus frozen section in ovarian cancer. Over to you, Dr. Kirtipal.
Thank you, ma'am. Thank you, Rahman. Good afternoon, and respected SAFOG President, Chairperson, Oncology Subcommittee, Oncology Committee SAFOG, and all dignitaries. With you not letting the time to go more, I am starting my presentation. The topic will be imprint cytology versus frozen section in cases of ovarian tumors. Next. I think we have some technical issues, so I would like to continue with this format only. The ovaries can be the site of various pathologies from benign to malignant, with the added problem of borderline lesions, and can be presenting the site of metastatic disease also. We can correct intraoperative diagnosis of ovarian lesions offers a possibility of adequate one-stage surgery rather than doing multiple surgery and second-look surgery, and helps to further plan management. This approach benefits all patients, especially when fertility needs to be preserved. The frozen section method was standardized in 1905 by Dr. Louis B. Wilson. Frozen section is the main diagnostic procedure till now, we all know that. However, this diagnostic tool has its own limitation, usually relating to the sampling errors or technical problems, such as freezing artifacts, and its cost. But in 1927, Dujan and Patrick developed simple method to obtain rapid cytological diagnosis for freshly caught specimen. Cytological smears have been shown as an easy, simple, rapid to perform and inexpensive technique which can preserve cellular details. Imprints prepared from fresh surgical samples give excellent cytological clarity. During the past decades, the application of both the cytology and frozen sections for intraoperative diagnosis of ovarian pathology has been discussed, and most of these studies compared these two methods and their efficacy and accuracy. But cytological evaluation is also superior to frozen section in few types of ovarian neoplasm, but in general, frozen section is reported to be more accurate. But imprint cytology should play mostly a very useful complementary role. So, and this was a study done at USA, which was that with the introduction of the cytological smears to ovarian frozen sections, the number of discrepancy and difference combined decreased from 13.75 to 7.85%. The most benefits of smear were observed in primary ovarian malignancy. Similarly, another study done in India shows that out of 50 cases, 21 cases were of ovarian, and out of those 21 cases, overall diagnostic accuracy from imprint cytology and frozen sections were 94%, and individually was 94%, but when combined diagnostic with cytology was done, it was 98%. The study concluded that imprint cytology alone may not be able to provide the correct diagnosis. So now coming to our study done at Paropakar Maternity and Women's Hospital, we conducted a study. The aim of the study was to see for ovarian lesion with histopathological findings and analyze the statistical effectiveness of this study, comparing with the imprint cytology finding. So the study period was of 10 months, done in 2018 June to 19 March. Total of 103 patients undergoing surgery for ovarian mass were included. So these included patients with grossly solid cystic neoplasm. For each cases, clinical, laboratory, and radiological data were also included. So coming to the techniques, this is an imprint technique, also the TORCH cytology process. First, gross specimen of the gross examination of the specimen is done, and the identification of the suspicious area is done, along with the on the cord section. So samples from imprint cytology were obtained from several parts of the lesion. Then gently, the suspicious parts were tossed with glass slides and smears were prepared. So those smears were immediately fixed with 95% ethanol, then were stained with papinicula stain, again were air dried, and finally were stained with Giemsa stain. This took around 15 minutes of time. So while evaluating cytology, smears were evaluated for cellular morphology and architecture. These results were compared with final histopathological diagnosis. So all benign and borderline lesions, as well as negative for malignancy, were all benign and borderline lesions were termed as negative for malignancy in cytology, whereas malignant lesions were termed as positive for malignancy. So the results were, we included 12 years to 68 years of patient with mean age of 34 years. Malignant ovarian tumor ranged from 12 to 51 years with a mean age of 35.7 years. So out of those 101 cases, we had 90 cases with imprint cytology negative and 11 cases with imprint cytology positive. But on final histology report, 85 cases came out to be benign, whereas 12 cases came out to be with malignant, and 4 cases came out to be borderline. So overall, there was a case discrepancy of 1 case, which was reported to be benign on imprint cytology, but on final histology, it came out to be positive. But 4 cases which were told benign on imprint cytology came out to be borderline tumor on final histology slides. So on benign condition, we found endometriotic cyst, mature cystic teratoma, and mucinous cystadenoma, similarly others. An interesting case was of endometriosis with an iridated cyst was also obtained. So on malignant, we found most commonly high-grade serous carcinoma, followed by mucinous carcinoma, immature teratoma, clear cell carcinoma, and so on. So coming to this final and important result, on TORCH imprint results, we total found 90 cases to be negative for malignant. Out of those 90 cases which were told malignant by the TORCH imprint, 1 case came out to be malignant. And all the 11 cases which were reported to be malignant by the torch imprint technique, all the cases came out to be malignant on final histopathology. So coming to few benign lesions, these are the slides of benign lesions which were taken from the pathology department. These are the slides of serous cyst adenocarcinoma, benign mucinous cyst adenoma, follicular cyst, we could see fibroma, and one important and interesting case during this study, we came across with very interesting case with iridoid cyst, which shows proctoscoliosis and booklets and with multinucleated giant cells. This was an interesting case and was later reported. So coming to those borderline lesions, where few borderline lesions were borderline mucinous cyst adenoma, borderline serous cyst adenoma, and coming to the malignant lesions, cyst adenocarcinoma was serous cyst adenocarcinoma was most common malignant lesion identified, followed by mucinous cyst adenocarcinoma, and these are the histological pictures found during the histopathological examination. So finally, let's compare our studies with the studies done at other part of the world. This was the study done at Japan, which shows diagnostic accuracy in benign, borderline, and malignancy was 90% in imprint cytology, and in frozen section it was 96.3%. The intraoperative accuracy of imprint cytology in diagnosing borderline tumor was although low in this study, but diagnostic accuracy for clear cells and mixed cell carcinoma was higher in imprint cytology than compared with frozen section. This was the another study done at Egypt, which reported total imprint cytology cases were negative, 36 were negative, and 8 were positive. So coming to the sensitivity, it shows sensitivity of 88.1% with specificity of 81.8%, with positive predictive value of 82, negative predictive value of and 87.8. So there are similarly different studies done at India also. We can see one case. We can see this study shows in specificity of sensitivity of 97.97% of imprint cytology and specificity of 91.3%, positive PPB of 95.5%, negative predictive value of 95.6%. These all results were of imprint cytology were compared with the final histopathological report. Similarly, another study done in India also showed similar results, showing sensitivity of 97.5% in surface epithelial tumor, specificity 94%. Similarly, positive predictive value is 96% and accuracy of 96.5%. But we can see there is 100% sensitivity, specificity in germ cells too. Similarly, other studies also done at India, also out of 50 cases, false negative was only seen on one case, which was borderline cyst adenoma, which was reported to be a benign cyst adenoma. Similarly, with it also showed sensitivity of more than specificity of more than 90%. So in our study, diagnostic accuracy was 99%, with sensitivity of 91.6%, specificity of 100%, positive predictive value of 100%, and negative predictive value of 98.8%. But the limitations during imprint smears are damage to cells when forcefully imprinting tissues that may impact morphology, because in imprint cytology, we are going to see the morphology of the cells. We cannot see the depth of invasion. So most of the time, there was seen damage to the cells, which causes difficulty in reporting, and limited evaluation for differentiation of tumor and fibrous lesion, hemorrhagic cysts that do not, this type of cysts do not release cells easily, so it was difficult for reporting. And finally, the time limitation, because it took around 30 minutes to report for a pathologist to report imprint cytology, for which the time waiting time for surgeon might be quite high. So coming to the conclusion of my presentation, intraoperative cytology is a very good complement to histopathologically. In developing countries where facility of advanced rapid intraoperative technology is not available, intraop cytology play very important roles in rapid preliminary diagnosis and it helps in surgical management of the planning. Still, countries like Nepal, where we have only few facilities for frozen section, in our center we are quite oftenly using imprint cytology, and it is helping us very much to perform surgeries, mostly during the time of fertility preserving surgery. Thank you, and these are my references of presentation, and this is my hospital, where do I work. Thank you so much. With this, I conclude my presentation.
Thank you so much,
Thank
Dr.
you very
Kirtipal,
much,
and,
Dr. Kirtipal.
Valia. It is
Thank you, Dr.
Alia for-
Kirtipal, for giving. Sorry, Dr. Bhagyalakshmi, sorry, if you want to say something.
No, please go ahead. Please go ahead. Requested Dr. Alia because she was, we missed her in the beginning.
Dr. Alia is probably mute. May I request Dr. Alia to please unmute? Probably she is having some problem there.
Okay, please go ahead. You please go ahead.
Let me
Yes.
conclude this session. Thanks a lot, Dr. Kirtipal, for giving such a fascinating talk on imprint cytology. Intraoperative diagnosis is important for young females, especially in those in which we are planning for conservative or fertility sparing surgery. And imprint cytology is simple, easily doable method, and it is commonly used as an adjunct for the frozen section. But in resource limited areas, we can also use it as stand-alone method because it is cheaper than the frozen section. But yet there are limitations of imprint cytology, as mentioned by Dr. Subedi, that it can differentiate between benign and malignant disease, but it sometimes, and also it can differentiate between clear cell and mixed type of carcinomas, but yet it has limitations. So we cannot say that we can, the imprint cytology can be used as a stand-alone where facilities are available. But yes, in resource limited areas, imprint cytology is an excellent method for intraoperative diagnosis. There was a question in chat box that do we only use imprint cytology as for the intraoperative diagnosis? No, yet frozen section is considered as a gold standard. But yes, in resource limited areas, it is very good because it is doable. It is easily doable, and the time limit for imprint cytology is lesser, as said by Dr. Kirtipal, and the frozen section takes a longer time. Dr. Alia, if you want to say something.
I just want to thank Dr. Subedi for such an excellent talk on this important topic. And I think for all SAFOG countries, which we have regions which have resource limitation, this imprint cytology may benefit. So those who have availability of both, they should complement each other, like frozen section and imprint cytology. But in those areas where we don't have excellent or readily available frozen section, we can use imprint cytology very well, knowing all its limitations. So thank you again, Dr. Subedi, for an excellent talk.
With this, thank you, everyone. Now, with this, I would like to continue our session. So our next speaker is Dr. Ramesh Fresh from Nepal. To chair this session, I would like to request Dr. Sheila Verma and Dr. Rubina Soel. Now introducing Dr. Sheila Verma. She's MD/MS from Lumba Friendship University, Moscow. She did a fellowship in gynecological oncology, and she's a master trainer of various gynae oncology subdivisions at Nepal, and she's currently president of Ghanaian Oncological Society of Nepal, and she's working as a senior consultant at National Hospital and Cancer Research Center. And our next chairperson is Professor Dr. Rubina Soel. She is a professor and director at Department of Medical Education, SIMS, Lahore, immediate past president SAFOG, vice president Pakistan Menopause Society, and member executive of SOGP and chair FIGO committee on VAWC. Our areas of interest are maternal health, GBV, neonatal health, menopause, medical education, unsafe abortion, and contraception. Now, I would like to request Dr. Sheila to introduce our next speaker, Dr. Ramesh. Yes.
Is Dr. Sheila there?
She's there. Ma'am, can you, Sheila?
Okay, okay. Thank you, Dr. Kirtipal. Thanks, SAFOG. Thanks, Oncology Committee, giving me this opportunity. I'm going to introduce Dr. Ramesh Shrestha from Nepal. Currently, he is an assistant professor, Department of Obstetrics and Gynecology, BPKISH, Dharan. He did his MBBS in 2010 and MS Gynae Ops in 2014, a fellowship in Gynea Oncology 2019 from India. He is a scientific committee member in Gynea Oncology Society, Nepal. He has 20 publications in various national and international indexed journals. He received many awards, such as Young Gynecologist Award, Soma Award, and Professor Ratnam Young Gynecologist Award. He got certificates of appreciation as a national trainer, cervical cancer screening prevention, and IGCS palliative care certificate in 2021. Faculty in AGOI Cone Annual Conference 2021, and a cervical cancer prevention course he has completed in 2019. He is a member of Gynea Oncology Society, and he is a member of AGOI and Surgical Oncology Society of Nepal, and he is a member of IGCS, and American Society of Clinical Oncology, ASCO, and Arabian Research Society of Gynecology Oncology. This is his introduction. Now, Dr. Ramesh, floor is yours.
Thank you, ma'am. Is my slide visible?
Yes, Dr. Ramesh. Yeah.
Good evening, all. Today, on the SAFOG Oncological Committee webinar, my topic is primary surgery versus interval surgery in advanced ovarian cancer, and which is still a continuing debate, and it is a continuing debate since long. Sorry, the slide is not running. I would like to share the slide again. Okay. The contents which I like to cover today is about the introduction of ovarian cancer, its epidemiology, and surgical treatment strategies and its evolution, and overlook of trials comparing primary surgery as well as primary chemotherapy, and at last I would like to go through the conclusion. Now, going through the introductions, ovarian cancer, it is not a single diagnosis of cancer. And it is an umbrella of more than 30 different types of ovarian cancers, and overall there is a wide variation in terms of incidence as well as in terms of its look. And out of those ovarian cancers, epithelial ovarian cancers is the most common ovarian cancers, and it occupies around more than 30% of the incidence. And out of those epithelial ovarian cancers, serous cancer is the most common cancer, and which arises from the ovary, fallopian tube, and peritoneum. This is the old Globocan data 2020, and over there the ovarian cancer among all male and females, comparing all those male and females, ovarian cancer is 19th in terms of incidence, while it is 15th in terms of mortality, and it is 11th in terms of 5 years prevalence. Advanced, as already discussed, advanced epithelial ovarian cancer, they are always diagnosed in the late stage. That is 70% of those epithelial ovarian cancer, they are usually present and advanced stage 3 and 4. Since it is diagnosed in late stage, that's why the 5 years overall survival is always low. It is only 30 to 40%. However, when these cancers were taken for surgery, the two factors which always prognosticate the overall survival as well as progression-free survival is the surgical outcomes during surgery and the response to chemotherapy. That is, if we can debulk the disease to no residual disease, then there is a good overall survival. Similarly, those ovarian cancer which has a good biology, that is, they are very, very responsive to chemotherapy, then they have good overall survival as well as progression-free survival. This is surgical paradigm shift regarding the treatment of surgical treatment of ovarian cancers. In the past, before 1990s, the ovarian cancer, this ovarian cancer, they were usually debunked regarding the mainly concentrating in the pelvis, and that's why the upper abdomen were never touched during the surgical treatment of ovarian cancer. That's why the treatment is always suboptimal. But in 1990s, before 2000, the debulking was mainly confined to peritoneal as well as the lower abdominal peritoneectomy with in-block resection of large bowel also. And that's why the paradigm has shifted towards the optimal surgery. But after 2000, there is a radical shift towards the concentrating the or addressing the upper abdomen also. And after 2010, the radicality has changed to addressing the supra abdomen also. That is concentrating or addressing the disease above the diaphragm. That is like thoracic debulking, concentrating the cardiopharyngeal lymph nodes and those dissecting the pleural plaques also. That's why the paradigm has shifted from the suboptimal towards the optimal, and now the goal has changed to complete cytoreduction surgery. In any ovarian cancer surgery, the goal is to remove all the macroscopic disease to no residual disease. That's why when we can devote our surgical skills in terms of patients to few hours more during the operative time, then there is additional advantage of more than months in the overall survival. We can see from here, if the surgical treatment is suboptimal, then there is overall survival of 30 to 35 months. But we can, if we devoted our time to few hours more during the operating time in the OT, then if we attend complete cytoreduction, then the survival, there is huge benefits in terms of overall survival in the patients up to 17 months. This is a side completeness of cytoreduction as well as surgical complexity score during treatment of CA ovary. Previously, before 2000, the surgical treatment was confined to hysterectomy, omentectomy, and lymphadenectomy. But after 2000, there is a radical shift in the surgical treatments. That is a radical shift in the surgical resection or radical treatment in the CA ovary scenario. And that's why the scenario has changed to pelvic as well as abdominal peritoneectomy, diaphragmatic strippings as well as splenectomy, and addressing the upper abdomen like river resection, distal pancreatic resection as well as small bowel resection. That's why the surgical complexity has a drastically shift from low to high complexity score during surgical treatments. And ultimately, the goal of this radical shift in the surgical treatment is to attain the complete cytoreduction, that is a complete cytoreduction to 0. When we discuss about the options for treatment options for advanced stage ovarian cancer, there are two options. That is, the standard treatment arm is the primary debulking surgery, which is followed by 6 cycles of chemotherapy. The other alternative arms is the neoadjuvant chemotherapy followed by interval debulking surgery, and it is again followed by adjuvant 3 cycles of chemotherapy. These are the factors which decides whether to go for primary surgery or primary chemotherapy, like tumor-related factors and regarding the extent and location of disease, center-related factors, that is high volume centers, they usually prefer for primary surgery, while low volume centers and centers which are evolved Ghanaian oncology, they are usually devoted to primary surgery, primary chemotherapy followed by surgery. And also there is patients-related factors like old age patients and patients who have multiple comorbidities, then they are usually pushed to primary chemotherapy followed by interval surgery. These are the Ethmois guidelines or consensus regarding the choosing for primary chemotherapy, like diffuse deep infiltration of the small bowel mesentery and diffuse infiltration of the stomach as well as viscera like pancreas. When there is deep parenchymal metastasis like liver and lungs, and when there is non-resectable lymph nodes, these are the factors which decides whether the patients have to be pushed for primary chemotherapy. This is again the algorithm given by ESGO as well as European Society of Gynecological Oncology. And in these algorithms, basically the patients were diagnosed with carcinoma ovary, then usually if they have if they have good performance status as well as if they have no any comorbidities, then they have to be assessed by staging laparoscopy during the intraoperative periods. And in staging laparoscopy, if the disease extent seems to be devolved to optimal or complete side reduction, then they will be taken for primary surgery. But if on staging laparoscopy the disease seems to be suboptimal debulk, then these patients were taken for primary chemotherapy. Now we'll discuss through various trials like EORTC trial, that the European Organization for Research and Treatment of Cancer trials. The other one is PORUS trial, which is chemotherapy or upfront surgical trials. The other one is Scorpion trials. And the other trial was done by Japanese Clinical Oncology Group trial. And last one, the Petroli et al. Study done by Petroli et al., which was published in Annals of Surgical Oncology. These are the trials which basically compare the primary surgery with primary chemotherapy, but still the doubt is unclear. This is the EORTC trial, and in which there is randomization of those patients diagnosed with advanced epithelial ovarian cancers. And to the standard arm is primary cytoreductive arm, and the alternative arm, that is group B, is or arm B is neoadjuvant chemotherapy arm followed by interval surgery. And this trial was published in New England Journal of Medicine in 2010. Here you can see there is no any several benefits between the two arms. That is, in primary surgical arm, that is primary debulking surgery arm, the overall survival is 29 months, while in interval debulking surgery, the overall survival is 30 months. But there is no any difference in the overall survival. The hazard ratio is 0.98, and there is no any, and it is statistically insignificant. Similarly, while comparing the complete side reduction as well as optimal side reduction between the two arms, in the primary surgical arms, we can see the complete side reduction, that is R0 is 20%, while it is almost double, that is 52% in the interval surgical arms. And comparing the optimal side reduction, it is 42% in the primary surgical arms, while it is almost double, that is 81% in the interval surgical arms. Now, the main interesting part is comparing the perioperative morbidity. The perioperative morbidity in the form of death, grade 3 or 4 hemorrhage, infection, and venous thromboembolism, it is significantly high in the primary surgical arms. But there is no any difference in the quality of life between the two treatment arms. This is the second trial, that is PORUS trial, chemotherapy or upfront surgical trial, and which was published in Lancet in 2015. Here also, those ovarian cancer patients, they were randomized to two arms. That is, the external arm is primary cytoreduction arm, and the second arm is arm B is primary chemotherapy and interval surgical arms. And it is all similar to EORTC trial. It is also a non-inferiority trial. In this trial also, there is no any significant difference in the overall survival between the two treatment arms, that is primary surgery as well as interval surgery. And also there is no difference in the hazards, that is 0.87, and it is statistically insignificant. Similarly, comparing to the complete side reduction as well as optimal side reduction between the two arms, we can see over there that the complete cytoreduction as well as optimal cytoreduction, it is significantly high in primary chemotherapy followed by interval surgical arms compared to primary cytoreductive arms. And similar to EORTC trial, the has a perioperative morbidity in the form of death, grade 3 or 4, adverse complications, infections, venous thromboembolism is high in primary surgical arms. But interestingly, there is no any difference in the quality of life between two arms. This is the pooled analysis of both the chorus as well as EORTC trial, and this is the forest plots. And over here, we can see that the primary chemotherapy followed by interval surgery, it is non-inferior to primary surgical arms, which is the standard arms. Hence, this shows that there is no difference in the primary chemotherapy followed by interval surgery as well as primary surgical treatment for ovarian cancers. Now there is heavy criticism between these two clinical trials when you consider the Western countries. In the Western countries, the criticism was that the R0, that is complete cytoreduction in both these clinical trials, is very, very significantly low in both the primary surgery as well as interval surgical arms. In the primary surgical arms in EORTC trial, it is only 20%, while in chorus trial, it is 70% in primary surgical arms. But in EORTC trial, in primary chemotherapy arm, it is only 50%, while it is almost 40% in the chorus trials. And the criticism were that in both the treatment arms, that is primary surgery as primary chemotherapy, the R0 reduction, that is complete cytoreduction, as well as the optimal cytoreduction is also significantly low in between the two clinical trials. Also, the median operating times in the EORTC trial is 165 minutes, while it is 120 minutes in the chorus trials. That is the median operating times, that is the time spent with the patient during the surgical treatment of C ovary is significantly low, and these times is less sufficient for complete as well as optimal cytoreduction of this patient during surgical times. Hence, because of this low complete as well as optimal cytoreduction, the overall survival in these two clinical trials is also low, only 29 months and 30 months between two arms in EORTC trial, and only 22 months and 24 months in the two arms in chorus trial. This is the third trial, Scorpion trial, which was recently published in International Journal of Gynecological Cancer in 2020. And in this trial, a new eligible criteria was taken so as to enroll the patient between the two treatment arms, that is primary surgery as primary chemotherapy. And the new eligible criteria taken was Fagoty laparoscopic score. And the Fagoty laparoscopic score was taken during the staging laparoscopy, and taking into consideration the six sites which were scored during the staging laparoscopy. And if the disease is more than 8, then they were taken for primary chemotherapy. In the Scorpion trial also, when we compare between the primary surgery as well as primary chemotherapy arm, there is significantly high complete cytoreduction as well as optimal cytoreduction in the interval surgery, that is primary chemotherapy arm, compared to primary surgery. Also, the surgical complexity score was significantly high in the primary surgical arms compared to primary chemotherapy followed by interval surgical arms. And if you compare the upper, that is this upper abdominal procedure, it is the upper abdominal procedure is significantly high in the primary surgical arms compared to primary chemotherapy. And obviously in the primary surgical arms, the operating time is significantly high, which is 460 minutes compared to 250 minutes in the primary chemotherapy arm. Similar to the two previous trials, that is EORTC trial and chorus trial, the median PFS was, there is no any difference in the median progression-free survival in between the two treatment arms. That is, it is 15 months in primary surgery, while it is 14 months in primary chemotherapy. But there is significantly increased overall survival in both arms, that is 14 months and 43 months, while it was in the range of 20 months in chorus trial as well as EORTC trial, comparing the median overall survival. Because in Scorpion trial, the rate of complete as well as optimal cytoreduction has increased. That's why there is increase in the median overall survival, though it is insignificant between the two treatment arms. This Scorpion trial was basically the primary outcomes was to see the perioperative morbidity. However, though there is no difference in the progression-free survival as well as overall survival between the two treatment arms, but there is significantly high perioperative morbidity in the form of major complication in the primary surgical arms as compared to primary chemotherapy arms. The fourth study is the Japanese clinical oncology group trial. It is also a non-inferiority trial, and in this trial also there is no any difference in the progression-free survival between the two treatment arms. Also, there is no any difference in the overall survival between the two treatment arms. However, similar to Scorpion trial, the overall survival, the median overall survival has significantly increased in the Japanese trial as compared to URTC and COROS trial. Now coming to the comparison of the cost between the primary surgery and primary chemotherapy. In the primary surgical arms, there is significantly high implication of costs, which is almost $31,000, while it is only $25,000. And this difference in cost was is a significant financial burden for the patients treated in the primary surgical arms. And this study was published in American Journal of Obstetrics and Gynecology in 2015. However, those patients who are taken for primary chemotherapy arms, usually those patients can be taken for minimal invasive surgical approach. And in this study, which is published in 2018, over here, almost 96% of those patients can be taken for minimal invasive surgery when they were taken for primary chemotherapy. And however, there is no any difference in the approach between the minimal invasive surgery as well as open surgery if you compare the approach after the primary chemotherapy arm. This study is published recently in Annals of Surgical Oncology in 2013, which basically highlights the potential risks of neoadjuvant chemotherapy when we consider the recurrence after neoadjuvant chemotherapy and surgery after full treatments. Over here, you can see in those arms which were taken for neoadjuvant followed by interval surgery, those patients have frequent carcinomatosis as well as platinum-free resistance during recurrence. And also these patients have shorter post-relapse survival compared to primary surgical arms when they recur after the initial treatments. Hence, the primary surgery, the debate between the primary surgery as well as neoadjuvant chemotherapy followed by interval surgery is ongoing events, and the debate is still continued. And hope in future these are the two trials. There is PROS trial, which is being taken by Germany groups, and the ASIN Sunday trial, which is being taken by the Shanghai Gynecological groups. Hope these are the two trials where there is homogeneous matching of those patients between the two, that is primary surgery and primary chemotherapy. These are two ongoing trials. Hope these two trials will settle the debate between the standard primary surgical arms and alternative neoadjuvant chemotherapy arms. Now going through the conclusion, in the standard care for early stage disease as well as stage 3V disease, the standard treatment is always primary cytoreductive surgery. But for advanced epithelial ovarian cancer, that is stage 3C and above, we should balance between the perioperative morbidity as well as optimal cytoreduction, take into consideration the patient's center as well as other risk factors when we consider between neoadjuvant or primary surgical arms. And there is growing evidence of neoadjuvant chemotherapy over primary surgical arms, and the key factors are passage as well as external disease assessment. And also there is less morbidity and mortality in primary chemotherapy arms with less operative time, and there is likely less cost. And also it facilitates the minimal invasive surgery when you consider primary chemotherapy arms. However, the issues of overall survival is the key issue which has to be considered in the primary chemotherapy arms. And the key issue is that though there is good R0 resection or optimal cytoreduction in the primary chemotherapy arms, but it does not translate into the good overall survival when we compare to the primary surgical arms, because the overall survival in both the primary chemotherapy as well as primary surgery arms is almost comparable, even though there is good R0 as well as optimal cytoreduction in the primary chemotherapy arms. And also there is a need of more robust randomized controlled trial, that is multi-centric trials with homogeneous arms and more R0 as well as optimal cytoreduction, so as to come to settle the debate between the primary chemotherapy as well as primary surgical surgery. With this, I would like to conclude my presentation. Thank you.
Thank you very much, Dr. Ramesh, for an excellent presentation. I think you went into a lot of detail trying to give the pros and cons of both the methods. We all know that the current recommendations for treatment of advanced FIGO stage 3 and 4 ovarian cancer have still remained unchanged from 2012. And therefore, the debate continues for want for more randomized controlled trials. However, the use of NAC has increased from 8.6% in 2004 to around 45% in 2016. But the overall recommendations and clinical practice continue to favor the primary cytoreductive surgery. Obviously, the cases at this point in time have to be individualized in terms of cost, in terms of the response that we will see from the patient. With this, Dr. Ramesh, I want to thank you very much. You have made a wonderful and a very detailed presentation on a very important topic, because this is a dilemma for most of the surgeons. Should they go for primary cytoreductive surgery or should they go for NAC? Thank you very much.
Thank you, ma'am.
With this, as we are already going out of the time, now we'd like to call our next speaker, Dr. Jitendra Pariyar, and to chair this session, I request Dr. Farhana Dewan and Dr. Yapa Y.G. Ratne. Dr. Farhana is President of OGSP, and she is Deputy Secretary of SAFOG, Head of Department of OBGYN from IBN SIN Medical College. She is a Professor of Obstetrics and Gynecology. She is Deputy National Coordinator of FIGO PPS Bundle Project Bangladesh since 2020 to till now. And she is Deputy National Coordinator of FIGO PPID Project Bangladesh 2015 to 2020. Our next chairperson, Dr. Yapa Vijiratne, is MBBS. Did his MBBS from Sri Lanka and MD from Sri Lanka, and is a member of Sri Lankan College of Obstetrics and Gynecology and a certified member of International Ovarian Tumor Analysis IOTO group. He has multiple publications, many oral presentations, and even 32 electronic poster presentations in conferences. And he is currently working as a senior registrar in gynecological oncology at the National Cancer Institute, Sri Lanka. Now, I would request Dr. Farhana to introduce our next speaker, Dr. Jitendra.
Hello? Yeah. Thank you so much. Can you hear me?
Yes, ma'am.
Thank you. Thank you very much. I would like to, now it's my pleasure to introduce Dr. Jitendra Pariyar in fellowship with, he has done his fellowship in gynecological oncology. He has done his MBBS in 1999 from Nepal, and MD also from Nepal University. He has got the fellowship in gynae oncology from Assam Medical Center, Korea, and then he is the gynae oncologist in Korean Memorial Cancer Hospital. He has done the training, and he is the Professor, National Academy of Medical Science, NAMS, and he's the mentor of IGCS and of the membership program. He is also the editor of the journal of PSRN, and he has many publications to his credit. Now I'd like to request Dr. Jitendra Pariyar to give his presentation. He will talk on fertility preserving surgery in management of ovarian carcinoma, optimism demystified. Over to you, Dr. Jitendra.
Thank you, ma'am. Thank you, Madam Chair, for your kind introduction. And I would like to thank the organizing committee, especially Dr. Kritipal, for putting up this wonderful program. And I'd like to thank the organizing committee once again for the opportunity for me to make this presentation on fertility preserving surgery in management of ovarian cancer, optimism demystified. Is my slide visible?
Yes, yes, Dr. Chandra.
So I bring greetings to you all from Nepal. We've been talking about this public health issue, ovarian cancer. And we have kind of reminded ourselves again and again, saying that this is a common gynecological malignancy in women, especially in our part also. And globally, we observe around 3 lakh cases every year, among which we lose around 2 lakh cases due to this disease. And it is quite sad to note that 1 in 75 women has the possibility of developing this cancer during her lifetime, and 1 in 100 women loses life from this cancer. And very sad to note that more than 60% present in advanced stage 3 and 4, because this cancer is a elusive one with a very confusing and vague symptoms. And this cancer has been known to be a silent killer. And among various malignancies in women, ovarian cancer has the highest mortality, as shown in this figure here, more than 64%. We have noted that ovarian cancer is an aggressive cancer, especially epithelial ovarian cancer, which makes the majority of the ovarian cancer. And its management also requires more aggressive kind of involvement. And we know that the primary treatment, of course, is surgery, as highlighted by my previous speaker. Total abdominal hysterectomy with bilateral salpingo-oophorectomy, omentectomy, and of course, lymphadenectomy. And when there are visceral involvement, probably debulk the viscera as well, like splenectomy, hepatic resection, diaphragmatic stripping and resection, to achieve R0 resection, so that this would give a better survival outcome and prolonged disease-free period. With these above facts, there are some optimistic notes as well. Some of the ovarian cancers do occur in younger patients rather than older, especially germ cell ovarian cancers, sex-cord stromal tumor. And it is quite good to note that some of the ovarian cancers, even epithelial ovarian cancers, can be caught up in early stage with ultrasound evaluation and good clinical evaluation. And it is even nice to note that germ cell ovarian tumor and many sex-cord stromal tumor, which occur, especially juvenile granulosa cell tumor, they occur in younger age, and they are unilateral in presentation, so making early stage. So the room for fertility preservation could be there. And it is very nice to note that in these mentioned ovarian malignancies, 5-year survival is very high if properly treated, like with good surgery, as high as 90%, as shown in this slide. So when treating young patients with ovarian cancer, especially early stage, especially malignant germ cell ovarian tumor and sex-called stromal tumor, we need to be more rational. We need to be thoughtful and we need to be compassionate, because we are trying to offer cure, and we should not forget there is life beyond cancer. And when the lady survives, she should have a good quality life, normal family life, and a happy life in the society as well. And it has been noted that gynecological cancers, like some of the ovarian cancers, do occur in reproductive age, when fertility sometimes is a concern. And a study done by American Cancer Society reported that around 1 in 47 women, when diagnosed with ovarian cancer, they were less than 40 years when they had fertility concerns. So in ovarian malignancy, of course, cure is our main target. And when cancer is treated, we would like to have a normal family life as well. So with better cancer treatment, there is better survival outcome, and fertility concerns, especially in younger group, becomes a major concern for a normal and meaningful life. We all agree with the fact that our life becomes very meaningful in a family, especially married life. And for a woman, motherhood is very precious, very important even. So when a lady in a reproductive age group is suffering from cancer, infertility or fear of losing her fertility is there. So this is a distressing situation, which has been noted in a study and reported by J. Carter and Dennis Che. Like almost 77% of the patients reported some kind of distress in relationship to loss of fertility when cancer was diagnosed. And as stated earlier, like with the better treatment modality, there has been better survival outcome. And when a woman beats a cancer, then she might as well be very confident enough to say that I am normal, probably I'll be able to have a happy family of my own. And it's very touching to note that a survey done in a breast cancer patients, 600 women, on inquiry, they had some concerns regarding being infertile after cancer treatment. So some of them even opted for less aggressive treatment and fewer chemotherapy drugs, so that their fertility would not be lost. So realizing this fact, American Society of Clinical Oncology and European societies have come up with certain recommendations regarding fertility preservation in cancer patients. Fertility concerns in ovarian cancer, can it be addressed? Fertility sparing surgery in ovarian cancer, is it possible? Can it be done? I would say yes. How can it be done? Of course, by saving the uterus and probably ovary as far as possible. And that would mean less radical gynecological surgery. And of course, ovarian transposition can be a technique. And when it comes to adjuvant therapy, of course, medical therapy like neoadjuvant chemotherapy and hormonal therapy could help. And it is nice to note that germ cell ovarian tumors are highly chemosensitive, and they can be taken care by chemotherapy even in advanced stage. And assisted reproductive techniques have evolved very well. So there is opportunity of embryo or ovarian preservation, cryopreservation. For this, help of infertility specialists would be highly appreciated and required. And last but not the least, there is always chance of surrogacy for those wanting a family of their own. Now, who are the appropriate candidates for fertility preservation in Ghanaian oncology? Well, of course, young, unmarried, and those who have not completed family. Regarding age, depends upon country to country and institute to institute, but most of the institutes and country would recommend less than 40 years. And regarding the pathology, stage of disease, clinical, imaging, and surgical stage is very important. And for this, again, pathology and radiological findings are very important. So stage 1 disease should be offered and are good candidates for fertility preservation. Regarding histopath, again, type of cancer, especially epithelial, when it comes to epithelial cancer, grade is very important. So fertility can be offered, fertility preservation can be offered for grade 1 and grade 2, usually. And responsiveness to chemotherapy. Again, we talk about germ cell ovarian cancer, which is also known to be medical entity. And fertility preserving procedures can safely provided to women who are willing to be compliant on regular follow-up. So even if recurrence is there, it can be caught up earlier, and then definitive treatment can be offered for chances of cure. Now, any new surgical modality should have good oncological outcome. So outcome should not be compromised. And regarding morbidity and mortality, it should be safe. So when it comes to fertility, the above two issues are important, as well as take-home baby or live birth rate is also equally important. Indications of fertility preservation in ovarian cancer, as I mentioned earlier, stage 1 disease, even in epithelial ovarian cancer, it can be offered. And in malignant germ cell ovarian tumor, which happens to be in younger age, all stages can be offered this treatment because these are highly chemosensitive entities. And in sex cord stromal tumor, again, any stage, because recurrence occurs late. So her fertility issues can be addressed in the meantime. And in borderline ovarian tumor, any stage, because it's kind of local pathology. Even if there are metastatic lesions, they can be safely excised, saving the uterus and contralateral adnexal. And according to European Society of Gynecology, grade 2 mucinous, endometrioid, and even serous cancers can be offered this. But grade 3, chances of recurrence is very high. And in guideline for treatment of these tumors, like as Dr. Ramesh earlier mentioned that for better survival outcome and cure rate, aggressive surgery is very important. But it is not so true for when we are talking about fertility issues. So our surgery should be conservative, like unilateral salpingo-oophorectomy or cystectomy can be offered, but with proper staging, like peritoneal washing, omentectomy, lymphadenectomy, and even appendectomy can be performed, but not hysterectomy or another excision of another adnexa, because that would compromise the fertility status. But when talking about cystectomy versus salpingo-oophorectomy, unilateral salpingo-oophorectomy is preferred because there is more chances of recurrence in the same ovary when cystectomy is offered in malignant cases. And of course, in this procedure, proton section or imprint cytology highlighted by Dr. Kirtipal earlier would be very beneficial, so as to tailor our surgery according to the need and condition of the patient. The outcome of fertility preserving treatment, where there are various publications, like one publication from US, study done by Dr. Jacob back in 2003. This was a 20-year long, from 1975 to 1995. They gathered cases of germ cell ovarian tumor, in which they collected around 102 patients, but for their study, only 64 were eligible. And it was very good to note that there were 38 live births, almost 60%. So the fertility outcome was very good in germ cell ovarian tumor. And when we talk about epithelial ovarian tumor, again, another publication by Maurice from France, which was a multicentric study, included 34 patients. Their recurrence rate was 31%, and the conception rate was quite good. And another study on borderline done by Swanton in large number, and they went fertility sparing surgery. In their study, the recurrence rate was as low as 16%. So this is a very good oncological outcome, and the conception rate was as high as 48%. And in our study, which was presented recently in NESO 2022 by my colleague, Dr. Poonam Lama, like in our series, we had 22 cases, all types of ovarian cancers. And these cases were collected over the period of 5 years. There were 4 recurrences. So the oncological outcome was quite good. The cure rate was as high as 85%. And live birth was 10%, which was almost 10 live births, which was almost 38%. So it was, our results were comparable to the other literatures and other studies. When it comes to advanced stage ovarian cancer, would there still be possibility of fertility sparing methods? Well, these advanced ovarian cancer cases need to be discussed with infertility specialists, psychologists. Multidisciplinary team discussion is important. And before definitive treatment is offered, like in the form of chemotherapy or surgery, ovarian preservation can be done. And of course, counseling can be made for surrogacy. When we talk about fertility sparing surgery, unilateral salpingo-oophorectomy with omentectomy and lymph node dissection, pelvic para-aortic lymph node dissection as a comprehensive staging procedure is very important, as shown in this picture. And I would like to share that consent has been taken from all of our patients to share their pictures in academic forum like this. So I would like to run through you about some of the successful cases. Like this young married couple, they were married for only 1 year. Unfortunately, the wife was diagnosed to have ovarian tumor, highly suspicious of malignancy because CA-125 was high and there was complex mass with ascites. So we offered her laparotomy with frozen section, and which was reported to be positive, but they wanted fertility preserving surgery. So with proper counseling, we offered her fertility preserving surgery, and it turned out to be serous cyst adenocarcinoma, grade 2, stage 1C. So she was offered adjuvant treatment, chemotherapy 6 cycles, and after 1 year, she conceived. And you can see very happy family with baby. So she is disease-free till now. It's been almost 3 years. And another successful pregnancy and delivery after granulosa cell tumor treatment with fertility preserving method. Like this lady, in fact, had left-sided ovarian tumor, which was presumed to be benign. So cystectomy was only done, and it turned out to be granulosa cell tumor. She was offered completion surgery, but she denied in the interest of having baby because they were newly married. So over the few years, she conceived. It was spontaneous conception and had C-section delivery. And at that time, we removed the remaining adnexa, left-sided, but it turned out to be free of tumor. So in fact, she was cured by first surgery, I would say, even with limited staging laparotomy. And another case of granulosa cell tumor successfully treated by fertility preserving surgery and adjuvant chemotherapy. And she did conceive recently, and she had C-section delivery. And this was a case of ovarian cancer during pregnancy. Like she presented in acute abdomen at 40 weeks of pregnancy due to twisted ovarian tumor. And you can see the fetus in utero. So emergency laparotomy was done. Fertility preserving surgery, limited surgery in the form of unilateral salpingo-oophorectomy and omental biopsy was done. It turned out to be yolk sac ovarian tumor, stage 1C, because ascitic fluid for cytology was positive. So counseling the family members and the patient regarding the need of chemo, because she carried early trimester pregnancy, chemotherapy was offered, which was accepted with fetus in utero. And she had cesarean delivery, and there was no sign of disease seen during C-section. And we have been following the baby over the years. Now he is almost 8 years with normal milestone, and the mother is free of disease. Another case of dysderminoma.
Dr. Jitendra, can you wrap up, because we are running out of time? I think Dr. Principal will agree with me.
Yes,
actually we are running
just
out
a few slides. Dysderminoma with pregnancy. C-section was done and later treated with chemotherapy, but did not have completion surgery. After 5 years, she had second conception and delivery, and it was noted that even without completion surgery, with chemotherapy only, she was disease-free. And another case of dysderminoma, stage 1C, again, after chemotherapy, after 2 years period, she had spontaneous conception and C-section delivery and happy family. So germ cell ovarian tumors are curable even with chemotherapy. And this, we gave a neoadjuvant chemotherapy, and she did have spontaneous conception. And this is a recent picture. So to sum up, fertility preserving surgery can be offered for Ghanaian cancer patients, especially ovarian cancer patients. In young ovarian cancer patients, it is possible, and it should be considered before offering or initiating the treatment. And regarding treatment of ovarian cancer with need of fertility preservation, multidisciplinary team, especially involvement of infertility specialists, is very important. So I think in today's era, oncology and fertility going together, oncofertility is emerging as a very rewarding entity as well. So over the past years, I've worked in cancer hospital, BP Koirala Memorial Cancer Hospital. I would like to thank the team there. I'm working in civil service hospital. I'd like to acknowledge all my team, and of course my Ghanaian oncology fellows and team. So with this, I'd like to thank you all for your patience hearing. Thank you.
Thank you, Dr. Jitendra. Dear audience, it's my pleasure to chair this very important session in the SAFOG Oncology Committee webinar. And I think we thoroughly enjoyed all the presentations. And I would like to comment a bit on Dr. Jitendra's presentation, which was really an optimistic one, because he has talked a lot and in detail and made it crystal clear that what is the importance of fertility preservation in ovarian cancer. He has very clearly mentioned about the cases, that is, it will be indication that is stage 1 carcinoma, epithelial carcinoma, germ cell, sex cord, and the borderline ones. And he has also mentioned that what can be done, what will be the type of surgery, what will be the follow-up, and how we can continue the pregnancy. And there was really a very beautiful pictures he showed with evidence. And the third very important thing I found, that when he showed the evidence, he showed that in the studies, we have seen that there were a lot of studies where the results were good, take-home pregnancy rate was good, and there is ended up with successful pregnancy, successful outcome. Also the evidence and also the results in his hospital where he is working. So dear audience, thank you very much. And I would like to thank Dr. Jitendra once again and thank the organizer for giving me the opportunity. Thank you.
Thank you, ma'am.
Over to you, Dr. Kritipal Subedi.
Dr. Yapa, would you like to add very few words?
Yes, sir and madam, it was a nice presentation, and actually we know that stage 1A and 1B, of course, there's place for fertility preservation, and when it comes to 1C is the challenging one, where 1C1 and 1C2, of course, some evidence are there. Of course, going ahead with the fertility preservation can be done, while the 1C3, where there's a presence of malignant cells in cytology or the cytic fluid, is not indications generally in most of the scientific literature. But it's very promising results have shown in this presentation, showing that very successful live pregnancies. So I think when it comes to our context, and especially the data also mostly available from the mucinous tumors and not from the high-grade serous cancers and all. So I think in order to add to my knowledge to this presentation, I think the evidence are good and also now promising data coming up in our area. So that's all I have to say. Thank you very much, and it was a nice presentation, very impressive.
Thank you, Dr. Yapa, for your kind words. Now Inviting our last but not the least, Dr. Yasmin from Pakistan. And to chair this session, I would like to request Dr. Dr. Ashok Padya and Dr. Inaya Abdul. Dr. Ashok is MD Obstetric Gynecology from BS MD Medical College, Burla. His fellowship in Gynecology Oncology from Tata Memorial Hospital. His fellowship in Advanced Gynecology Oncology from USA. His fellow trainee in robotic surgery from Roswell Park Cancer Hospital. Presently assistant professor at Cuttack, Odisha. He's executive member of Association of Gynecologists of Gynae Oncologists of India. He has received R.N. Ganguly Public Awareness Award at National Conference of ISO BARD and honored with ABC Foundation Award for research related to cancer cervix in 2013. Our next chairperson is Dr. Inaya Abdul Rahman. She's member of Oncology Committee, SAFOG Maldives. Our areas of expertise, OBGYN, colposcopy and pre-invasive cancer treatment, basic ultrasound, and ACLC is an ACLS provider. She is a consultant obstetric gynecology in Ul Umalia Hospital, Maldives. She has multiple publications, and our areas of interest is antenatal care and cervical cancer. Now I'd like to request Dr. Ashok to introduce our next speaker, Dr. Yasmin Abdul.
Yeah. Good afternoon, one and all. Am I audible?
Yes, sir.
Yeah. So good afternoon, one and all. At the outset, I'm thankful to the organizer, especially Dr. Kirtipal, Dr. Bhagyalakshmi, who is my teacher, my guide, my philosopher, who is always stands before me in every crisis of my life. And so I'm thankful to again the organizer. And let me introduce our speaker, Dr. Yasmin Abdul. Dr. Yasmin Abdul Rashid graduated from Kuwait Azam Medical College, Bahawalpur, Pakistan, did her internal medicine training at Liaquat National Hospital and medical oncology training from Aga Khan University Hospital, Karachi, Pakistan. She is working as a consultant medical oncologist at ACUS since 2011, currently in the capacity of assistant profession program director of medical oncology residency training program. She has interest in managing solid malignancy, especially head and neck, lungs, and breast gynecological cancer. She had numerous research publications, collaboration, and was principal investigator in SAFOG International Multinational Phase 3 trial SC Trastuzumab in early breast cancer. She had been a very active member in instruction of postgraduate medical education committee and also contributes in advisory capacity for different clinical oncology setups across the country. She is a founding and executive member of SMOP, that is Society of Medical Oncology, Pakistan, and currently serving as a General Secretary, SMOP. And today, she is going to present about immunology in the field of ovarian cancer. So over to Dr. Yasmin, role of immunotherapy in ovarian cancer. Dr. Yasmin, please.
I hope you can see my slides.
Yeah, we can do it.
Yes. Thank you so much. Thank you for the kind introduction. Good afternoon, Assalamu alaikum, and namaste, everyone. First of all, I'd like to thank the organizing committee of SAFOG, especially Dr. Ali Aziz for nominating me and Dr. Kirtipal for your cooperation and for inviting me for this prestigious meeting. So in the next 15 minutes, I'm going to talk about the role of immunotherapy in management of ovarian carcinoma. Personalized medicine is here. Since we are using the word personalized, I would like to briefly talk about it before moving forward. So precision medicine or personalized medicine is a model that separates patients of same malignancy into different groups so that treatment can be tailored to individual patients' needs based on their clinical, pathological, and molecular factors. Since there have been a lot of revolutionary treatment options which were approved in ovarian cancer in maintenance setting and in advanced setting, we cannot complete the talk without mentioning those concepts and few terms before we talk about immunotherapy, because without that we cannot understand the role of immunotherapy in management of ovarian carcinoma. So bear with me for initial few slides. These are my disclosures. So I'm not going to repeat the epidemiology and statistics because these have been discussed already by different speakers. But important point to note is that majority of epithelial ovarian carcinoma cases are not associated with genetic mutations. Estimated 18% of these cases are associated with germline mutations, and most of which are due to BRCA1 and BRCA2 mutations. So despite optimal debulking surgery and curative surgery and platinum-based chemotherapeutic combinations, which in most of the cases effectively induce remission. But most of these women, unfortunately, they succumb to recurrence and treatment-resistant advanced disease despite achieving significant rates of clinical and pathological complete responses. So there's a need for better targeted options, and most recently, the role of immunotherapeutic agents have been explored in this setting. So this was a concept which was explored and has impacted progression-free survival and overall survival in patients with ovarian cancers, that is targeting measurable residual disease. So in detecting, profiling, and targeting of MRD has meaningfully improved outcomes in these patients. Role of maintenance, frontline maintenance, and maintenance in recurrent advanced setting has revolutionized the outcomes of ovarian cancer. Most importantly, from moving on from paclitaxel maintenance to anti-angiogenic agent-based maintenance, that is on the basis of TOG and ICON-7 trial from 2011 onwards, and then most recently in introduction of PARP inhibitors on the basis of SOLO-1 and all these trials. PARP inhibitors alone and in combination have significantly improved the survival and quality of life of these patients. This is a slide showing advent of maintenance therapy in advanced ovarian cancer. So briefly talking about genetic testing or referral to oncogenetic clinic, which is recommended as per guidelines for all patients diagnosed with ovarian cancer these days in early or advanced stages. And both germline and somatic mutations are recommended. Germline mutations are inherited or hereditary mutations, while somatic mutations are acquired genomic variations in DNA which occur from damage to genes during a person's lifetime, and it does not pass from parents to children. If germline testing is negative, we still proceed with somatic testing because we can identify patients who will most likely benefit from the latest drugs, that is PARP inhibitors. If you rely only on somatic testing to identify patients, patient selection for reflex genetic testing, you might miss 5% of germline mutations. And if you rely only on germline testing, you might miss approximately 7% of patients who can be picked up on somatic testing. So it's important to do the both. As I said, PARP inhibitors have revolutionized the management of ovarian and breast cancer treatments. PARP inhibitors, they lead to trapping of PARP proteins on DNA in addition to blocking their catalytic action. This interferes with replication, causing preferential cell death of cancer cells and hence better control of disease with better quality of life and less toxicity. So on the basis of BRCA status of the patient and evidence based on SOLO-1 trial, which used olaparib, a PARP inhibitor in maintenance setting and for frontline, these should be considered standard of treatment for all women newly diagnosed advanced ovarian carcinoma and whose BRCA is mutated. This testing should be offered to all patients. But what about patients who have wild type BRCA? What about them? So for them, we need to understand the concept of homologous recombination deficiency, or HRD. This is the inability of a cell to effectively repair DNA double strand using homologous recombination repair pathway. And loss of function genes involved in this pathway, that is HRR pathway, can sensitize tumors to PARP inhibitors. These, that is the drugs which are approved in this setting, and platinum-based chemotherapy, which is mainly historically the backbone of treatment of ovarian carcinoma. And this targets the destruction of cancer cells by working in concert with HRD through synthetic lethality. So, what does this mean? This means that even if patients are BRCA wild type, but if they are HR deficient, they will still respond to PARP inhibitors, which is evident by these two trials, which that is PRIMA, which used in which niraparib was used irrespective of BRCA status, and these patients were HRD positive. And in PEROA trial, PARP inhibitors were used in combination with anti-angiogenic agents, and you can see statistically significant improvement in study arms. But if patients have HRD negative status, you can see the curves are merging and there's no benefit in these patients. These are few trials in frontline and maintenance settings of PARP inhibitors in BRCA mutated and BRCA wild type HRD positive and BRCA wild type HRD negative advanced ovarian cancers. And as you can see, the patients who benefited most were the ones who had either mutated BRCA status or who were HRD negative. The ones with HRD positive. The ones with HRD negative status did not benefit much from PARP inhibitors. So now moving on to the latest immunotherapy and immunotherapeutic agents in oncology have revolutionized the management of most of the solid and hematologic malignancies in early and late stage. This is a treatment that uses body's own immune system to help detect and fight cancer. So the goal is to overcome the mechanisms by which tumors evade immune system, thereby allowing recognition and destruction of cancer cells by the host's own immune system. So, these immune checkpoint inhibitors or immunotherapeutic agents are known as PD-1 or PD-L1 blockers. What is this? This is actually a member of immunoglobulin superfamily. This is expressed by both effector and regulatory T cells, and PD-1, PD-L1 interaction is involved in tolerance and chronic inflammation. And this contributes to functional T cell exhaustion during infection and cancer. Hence, its blockade is important to control cell proliferation and metastasis. So, what is the role of immune checkpoint blockade in epithelial ovarian cancer? The results of multiple clinical trials investigating immune checkpoint blockade have revealed low levels of activity of single agent immune checkpoint inhibitors. And when immune checkpoint blockade were combined with different therapies in this setting, that is ovarian carcinomas, we have not yet been able to identify robust activity in significant proportions of patients with epithelial ovarian carcinoma. So we need to know which subset of patients with ovarian carcinoma have shown improvement and have shown objective response rates with these agents. So we know that women with platinum-resistant ovarian cancers have overall survival of less than 16 months, even if we combine chemotherapeutic agents with anti-angiogenic agent. So hence, we need to understand the concept of immune checkpoint blockade. Tumor-infiltrating lymphocytes, which play a significant role in immune checkpoint blockade, exhibit cytotoxic activity against autologous tumor-associated antigens. But there are other cellular and non-cellular factors in the tumor microenvironment which interact and determine the overall tumor immune response. What does this mean? What is tumor microenvironment? You must have heard this word from medical oncologists a lot of time. So briefly, tumor microenvironment refers to the cellular environment in which tumors, and cancer stem cells, they coexist. Cancer stem cells have the ability to self-renew and drive tumorigenesis. So tumor microenvironment has blood vessels, cancer stem cells, lymphocytes, everything, and inflammatory cells. They are different from normal microenvironment. And there are mainly two groups of tumor microenvironment. That is, in the ones with immune infiltration. These are these three types. In the interest of time, I'm not going into the details. These are very interesting concepts, but these are time consuming, so I'm not going to discuss these in detail. And this type is cold type, that is cold tumor microenvironment, that is tumors without immune infiltration. And ovarian carcinomas, unfortunately, are considered to be cold, to have cold tumor microenvironment. Hence, most of the immune checkpoint inhibitor trials were negative. But how can we make convert a cold tumor into hot tumor? That is, make them responsive to immune checkpoint inhibitors. There are strategies that have effectively convert cold tumor to hot tumors, and that is by improving T cell infiltration. This can be done by adding other chemotherapeutic nanomedicines, which enhances tumor antigens and promote T cell priming and infiltration, thus making immune checkpoint blockade effective even in tumors which are considered cold, like ovarian carcinoma. So before moving on to the slide with clinical trials which have shown efficacy in ovarian cancer, there are two terms which are important: deficient MMR or MSI high and tumor mutational burden. On the basis of these two predictive biomarkers, you decide whether your patients will benefit from immune checkpoint blockade in ovarian cancer and few other cancers. So this is, MMR is mismatch repair. It's one of cell's mechanisms for repairing damaged DNA that results from single base pair insertions or deletions. And this type of DNA polymerase error occurs at areas of short repetitive DNA sequences, which are called microsatellite. Hence, this is microsatellite instability. So deficient MMR can be detected by looking at the variation of length of microsatellite in normal tissue and then compare with its length in the patient's tumor tissue. And when high rate of variation, that is H stands for high, when high rate of variation in microsatellite length exists across the tumor genome, it is said to have high levels of microsatellite instability, which eventually reflects deficiency in mismatch repair. And these tumors are inherently responsive to immune checkpoint blockade. And then another term, tumor mutational burden, which refers to number of non-inherited mutations per million bases of investigated genome sequence. This can be measured by next generation sequencing. By the way, MSI high can also be detected by either IHC, PCR, or preferably with NGS. So this tumor mutation burden is also, a potential biomarker of benefit from immune checkpoint inhibitors, and this differs across different tumor types. When there are 10 or more than 10 mutations per megabase are present, you call those tumors as tumor mutation burden high tumors, and you can consider immune checkpoint inhibitors. So on the basis of Keynote 158 study and another study in which different solid tumors patients with different solid tumors were enrolled, including colorectal carcinoma, pancreatic, cholangiocarcinoma, endometrial carcinoma, and ovarian carcinoma, the pembrolizumab immunotherapy was approved in patients who had deficient MMR or who had high mutational burden. This approval was largely based on response rates and not based on other more meaningful clinical endpoints. And this was approved for patients who have progressed following prior treatment and who have no satisfactory alternative treatment options left. Dostarlimab was also approved in the same setting with same predictive biomarkers. And you must have heard about dostarlimab in rectal carcinoma, and this was recently published in Time magazine also, which has revolutionized the treatment of early rectal cancer also. So I'll just describe the gist of this slide. This slide mentions key clinical trials of single agent and combination immune checkpoint blockades in epithelial ovarian carcinoma. So the gist is, when immune checkpoint inhibitors were used in patients who were platinum sensitive, they were more effective. When they were used in BRCA mutant patients, they were more effective, and they were most effective when they were used with either with immune checkpoint, either with PARP inhibitors or anti-angiogenic agents. So briefly, 2 slides on a rationale for combination of immunotherapy and VEGF inhibitors, that is anti-angiogenic agents, and PARP inhibitors. Angiogenesis is also a mediator of immune regulation in tumor microenvironment. Hence, anti-angiogenic agents can stimulate immune system and enhance the therapeutic effect of immunotherapeutic agents by synergistic effect. And PARP inhibitors also have immunomodulant effect, and the rationale for combining both immune checkpoint blockade and PARP inhibitors. I'm not going to go into the details of these 2 slides. These are ongoing clinical trials exploring immune checkpoint inhibitors in different combinations, and ongoing clinical trials exploring immune checkpoint inhibitors with cancer vaccines and alternative cancer therapy products. So on the basis of these 2 trials, the most recent guidelines have incorporated dostarlimab and pembrolizumab for patients who have deficient MMR or high tumor mutation burden in advanced ovarian carcinoma. So to conclude, ovarian carcinoma treatment paradigm is rapidly improving. There have been tissue agnostic approvals based on high tumor mutation burden and MSI high for patients who do not have meaningful alternative treatment options. 2 agents, pembrolizumab and dostarlimab, have been approved, but we still need to employ novel technologies to discover transformative, better predictive biomarkers. We need to understand tumor microenvironment and so that we can develop immunotherapies which extend beyond immune checkpoint blockade, and combinations which help these agents work better. We also need to understand resistant mechanisms of each agent, which will help in improving sequencing strategy in advanced epithelial ovarian carcinoma, hence improving prognosis of these patients with better quality of life. I hope this was not overwhelming. I tried my best to present these concepts in the most simplest way I could. Thank you so much for patient listening.
So, please unmute. Dr. Inaya, can you add some remarks?
Good evening. Excellent presentation, Dr. Yasmin. Immunotherapy is of course reshaping our cancer treatment paradigms. Response rates depends to immune therapy depends upon the tumor microenvironment, how Dr. Yasmin has explained, and it depends upon the host's pre-existing anti-tumor immunity. So combining immune therapy with conventional treatment modalities, it can improve the response rates to cancer and maybe improve the women's survival rates. Excellent and a wonderful presentation. Thank you, Dr. Yasmin.
Thank you for the invitation. Thank you.
Also, would you like to add? Otherwise, we'll be coming to the end. I think he's not. It was there, but I think we'll, by this, we come to the end of a scientific session. So this was a wonderful scientific session. It was really, we know burden of ovarian cancer has been increasing worldwide and also in our region. But the lack of the proper screening tools and late symptoms is mainly responsible for this silent killer disease. Hope our webinar add a little benefit for all of us to make more conscious, and it added more knowledge to us. Finally, coming to an end, I'm absolutely thrilled. Thank you for the webinar today. It was a pleasure to attend, and you all helped me articulate parts of my role and consider new aspects of leadership also. This webinar will be able to carry the lessons learned there going forward. Thanks again to all our speakers for sharing your knowledge. There are no words for thanking our chairpersons for attending the program and guiding all of us on the deeper aspects of the topic. I'm very grateful to our SAFOG President, Dr. Rohana Sir, General Secretary, Dr. Yusuf Latif Sir, and SAFOG Onco Committee Chairperson, Dr. Alia Begum, for bearing me for all my mistakes during preparation of the program. My sincere thanks goes to Professor Dr. Bhagyalakshmi ma'am, who had guided me from the beginning of the planning sessions till I am presenting here today. And my sincere thanks to everyone whom I have missed taking the names. So finally, I am grateful to our wonderful audience who managed the time for this webinar and without whom the program wouldn't have been successful. Lastly, I am very thankful to Nepal Research and Educational Network, NREN, who provided us the Zoom link and technical help throughout the program. With this, I would like to end this session, and thank you everyone for keeping up till the end. Although we are planned for 2 hours, but it came to be 3 hours. And thank you everyone for staying till 3 hours. Thank you so much.